Good morning in Yahweh. I'd like to welcome each and every one of you to our 2023 Non-Communicable Disease Conference, or better known to many of us as NCDs. My name is Jean Phillip. I work with the Ministry of Health as a general practitioner. It is an honor and privilege to be standing up here as your MC today. This conference will be a platform to provide NCD awareness, as well as to bring together a strong collaboration for a multi-sectoral approach to combat NCDs in the Republic of the Marshall Islands. With this year's 2023 NCD theme entitled Bridging the Healthcare Gap, Plan and Action. Without further ado, to begin the opening ceremony, I'd like to call upon Ministry of Health Chaplain, Reverend Bewich John, to come bless our program with the opening prayer.
Molemci, Chuchar, Kemijina Barrego, and Jalabalap, Yo de Jamlap, and George Karagan, Yenigan Raman, Kemiko by Pendron, Jonini and Elaba Mauruk, Jamagad Ministry Am, Yo Yerugi, Charabali Lulurjaga, Edmur, Lagin, Republicina, Kobado Gipan Taiwan Health Center, Imalapan College in War, Yerugi, and compare the Nangnimich in City. Makata mon malok ilo lajaragin program inam cipung nan rainin kemijilukun kamolulu kena heberipam kiene wam ceban ailing kina me virgin employees lady yu cine ailing kin minister rain emruder rain am ilo tubla me adu corp malip rodum cich rar kobado jan ministry operainot rain odum jiri kobado beren kobai pen rodum region bugot ane malago kapchukun nor ilo ailing kin Orjonalen kami katai kami man mejam rio jangan yuk enu chonani jio ichinon kamal boy menudum chich rabe jaga borin pugchigir nan ko kami bojan ramon jagi rakarangan yin ngai char boy menudum chich ini jilo karak iman kilamali jenrin kami char aje ojinin porchonalen rabada ko boy nam pendron ilo chiponen reni ilo dam chisis ilo kanana ko am rabada iteligam ilo miligi yenudum chich jenrin nam char komolot amen.
Thank you, Reverend Bewich, for the prayer. At this time, I'd like to invite and congratulate as well our newly appointed Secretary of Health, Francine Waze Chaglik, to give the introduction and welcoming remarks.
Yahweh Oleb. Chala ka puer. Yahweh ang Oleb, eno Oleb perluin medjigi yodalo cipongan raini nagay. Ako mukta aja na ledok nanin kajaramman yo. Marga kacit pero kacojo bacin. Chojum chudak chiragum na kaude ronum Yahweh ronum per NCD mini je would physically move around. Acknowledge everyone, say Yahweh ni hao. Como tada. Komol, you may be seated. Yahweh, good morning, Anolip. Kamolo lana again, Meur, Major Meur. Komol Chin again, welcome, Yawam. E. Kaude Jurojim Lero Jorwarjen, Ralik Caprada. Kaude Kum, and Odan Chin Bang, Yodangan, Karwaini, Ledonan, and Karwaini Neogen, Rayawan Chicken and Meurum, Chikile Oleb. Ilo amiyang karkopado gulo NCD Summit in 2023. Kaude ragay piwich kananin charam kajaramanewan raini na makalben yen ngin janik peripendo. Parainod kalir ruday jaren rarkopado gulo rainin His Excellency President David Kabua, First Lady Ginger Kabua, Honorable Minister Otak Kisino, Ambassador Chao, Vice Minister Kadalang Kabua, Vice Superintendent Dr. Hua, Director Chang, Japan Embassy Nakamura-san, thank you. Ichudak Ijaniman, Chuan newly appointed Secretary Bayo, Ilabalukun, humbled and blessed for this appointment. Kamolo Roral, Ledogini Nibar, Kaleba Romer Arbar Pello, candidate CEO, Pue, Ibojakan Parche Charabali Pair. And what Chuan Matamilo Rayawan Chicken Edbur, Chuanum Ubara Kanudage, Imanana, Ibaruan, Iloar Koba Ipendon, Ilo Samadin and Raini, and Lowigin. Im Kanwin Talne, Emiana Elajarak, Bridging the Healthcare Gap, Plan and Action. Agalo Kajinar Chamarompa, Chenan Kijua de Jemur, Pajan Chibaroro. Ikanan bar Kaidola Mejadodo, Im Chitabun, Kalim, Kajaraman, Gan Kajui Kachojo, Raiwan Chicken Jemur, Romatalo Taiwan Health Center, Nikki, and the team. Kan Kajan Mejaguami when Maron Tabarak Rainin. Loami with Maron Chudak Wadum Katabar Chinchinon, planning yo, Payan Kamani Charbal and Pabarai and CD. Chenbar Kalim Kauda Yoro, Tarbar Kajan Mid, Ilo, Air Kamani Charbalawan and CD. Elaptadang and partners roarang. Im Raberipper, Imiganala Chun Kile, Im Parkarawainin and Rain Raridok, Kujile, Ber Prajadane Wire, Miss Lydia Tiban, Arma and CD Coalition, Wellness Center, MIP. For your unwavering dedication, your partnership, our partners online that have joined us, Dr. Sai from Secretariat of Pacific Communities, SPC, Dr. Kanda and World Health Organization, Rochet Me Robert Chenibaya, Robert Pello Zoom. Your commitment to excellence has undoubtedly contributed to the progress of NCD engagements, and for that we are truly grateful. Parchuan Allen, Charaman ngan kajoy kachoyo, kajadarigirig boy kumanay marong wan malak, katabar, chabareod menim katabareo no dilo theme nareng, plan and action, ayen marbar, kumol.
Thank you, Secretary Francine Waze Chagli, for the beautiful introduction and welcoming remarks to all our distinguished guests today. Sorry. May I now call upon His Excellency Republic of China, Taiwan. Sorry. May I now call upon His Excellency Republic of China, Taiwan Ambassador Steve Xiao for our keynote remarks.
His Excellency President David Kabua and First Lady Ginger Kabua and Honorable Minister Otak Kisino and also Minister Kilan Kapua, and also Vice Superintendent Dr. Chen Zihua of Shuangwen Hospital, and the delegation members, and also Secretary Francine Waze Chagli, and distinguished guests, ladies and gentlemen, Yakwe, Olap. And it is my great honor to be invited to the opening ceremony of 2023 Non-Communicable Disease Conference. Firstly, I would like to extend my heartfelt gratitude to Ministry of Health and Human Services, and also Major Hospital and the Taiwan Strong Hospital for co-hosting this conference and providing a platform that healthcare professionals can get together and discuss how we can fight against the non-communicable disease. Since its inception in 2007, the Taiwan Health Center has been working closely with the MOHSS and also Major Hospital to provide better health care and services to the Mauritius people, particularly in the area of bringing new blood to the medical staff. So as part of its mission, the Strong Hospital dispatched a number of doctors with different specialties in a number of, during the course of the year to Major Hospital. In addition, this year we witnessed together the handover of the solar panel parking energy storage system and also oxygen supply system in May, and donation of wound care ornaments by Dr. Zhang Shunchen in July, and also the donation of urological equipment and supplies in August. So all of these are love from Taiwan, and I believe that you can feel it. Except in having doctors from Taiwan to station in Major Hospital, I'm delighted to see that Marshall Islands have their own medical doctor. So since the start of the residency program, we have seen Dr. David Alfred and Cody Jack, the first and the second medical school graduates from Taiwan, complete their internship medical training. And now David has just completed his residency at the Strong Hospital in Taiwan and returned home as the first ever Taiwan trained general surgeon, marking a new chapter in medical cooperation between the Republic of Taiwan and the Republic of Marshall Islands. As we know that Taiwan can help and Taiwan is helping, and I believe that Vice Superintendent Dr. Chen of Strong Hospital and his delegation members will be more than happy to share their experiences in fight against NCDs. So in addition, another delegation from Taiwan's Ministry of Health and Welfare will be visiting Majuro on Sunday, this coming Sunday, to evaluate the medical exchange and the cooperation project in the IMI. And they are going to share experiences also on the establishment of hospital information system in the recent years, as well as medical training projects, and the very important introduction of laparoscopy. I think that's very important part of the project will in the future. So once again, I would like to thank MOHSS and also Major Hospital, and also the NGOS here in the Major, and also the Strong Hospital for organizing such a tiny and important conference. So I wish this conference a very big success. Gomo Tata, thank you very much.
Thank you, His Excellency Ambassador Steve Xia. For our closing remarks, may I ask Honorable Oda Custino, Minister of Health and Human Services, to please come forward and say a few words. Thank you.
Come on, MC. Ya ko chupong analip. Malaray nan ligada nanin na kilim kamolol nga nani jabaru jilang. Kan iyanin kan nor majmuro ngan kejuj kacuju mailing kinar. His Excellency President David Kabua, First Lady Ginger Kabua, Komol Lamiro Garkova, the Chupong Raining, Excellency Ambassador Sao, and Minister Kutlang Kabua, Komol, and Vice Superintendent Dr. Chen. Thank you for being here today. Nan Brianot Kalaga Kili Chairman and Council of Aniroj. Maurab Birojum Nirojro. Honor of Brianot, Miro jorocet lo pelagan majalin im jogocet. Kle Brian speaker Katie ka pai speaker ar im rugai loro jet matair im matar lo jadi jalao. Sip secretary ar lo ailing kain im secretary matu secretary akail ngan jigina jmoro. Em Brian kle olop takada de jerin rabari per lo cipagun rainin. Como dengan ami kadegum kan jarbalin bayan erro kan kiyuj maule brujar barocet ilo rayawan jigune jmuro nan prainot ko alaga kile honorable mayor on island majoro Larry check awle honorable mayor an kajujo island kinar kile incio gain imreja ikejel dogu pen rayawan jigune jmuro robert per lelagar nanin kile in kamolor gagior kapelok yeni naru jilo cepong rainin cuan kile ojan olong ngan lero is the set kya kapala bewan predin ilo haru kudok yin company charabal kin raur ngan kejeparok ejmeruan armijin majal lelagar nanin kamolol kan charabalin purgu ko aru ipen kine aru nan pagcirigian ngana lelaga nanin kamolol im kile rojar barro matarjen Taiwan Health Center yo rayawan chigine murum ro ilo NCD conference 2023 coordinating committee on writing eligdada mechebrigdada nanin kile ngan kumu jawlep kumar ko bado gelo chupagunen rainin como mol kanami gar meron jolok yen wami ko bado gelo chupagunin alba udit pai meron podo kanano lo yini nelap maur ngan lal chiri giraru lo NCT conference akwe lagu ni kaman lo yini ibe ebayan gar pen eliginan gar COVID-19 chelet lalinar yo me pero di mantada ilo charbal kinan kieno yo ke kacuju ministry maulo boro ilo cuju kun per koar ilo aru cumur kamani yo konar ngan pobrai nangin miskin ilo ani yo ko chulu recam lolok car lo elang ben ko relap im charbal ko perainu mening jibang ko rar pekcigir ilo ar celmai abang ko me colok kedemene ken gar pekcigin Emrecet mengo cemerung wadage raga wadada emi ijija anwala gelo meurin. Ipen nangin mijigin ewarali kar nangin mijigo chet rever kariri and with non-communicable diseases go nangin mijigo walo jenin city. Imi menyair celet congonin cimjurung cilu pasenin meuran armich. Roy menyair emagit cen meurin. Alben menegin ro rar kaman. Pen and lau ciri kinar merong tabar katabar kawan ikicin Sustainable Development Goals 2023. Echala kukutak Republic of the Marshall Islands jen lau ciri kocet iloan cap emman cukun ejemur iloan erolok kini war kena ipelal kocet kencet lo urin pelin pasibigi ikicin nangan mejen NCT. Ngan kala jara katan ceria nangin mijigain rajwalo gain no tangal eye blood stroke cancer kochat alangai na rigolok nampayo an nangin mijigain in na mena jala bolok kademene igi chen boru mej boru lokit ilo karok do war oran jon ranin roto jin chongoroyo former president wan gar RMI Teryo His Excellency Christopher Chorabun Loyak declared Chuan state of health emergency ngan NCD. Aralikar ke kacuju raguan kian ra prainot emmagatekarangan wawin impeve kap karko arwala ke terin ikatan 2013 and 2018. Many in arbar alikar lo NCD National Strategic Plan yo. Ijo image lulur jage ekara ke ini kichen nangin mejugo walo chen NCT ilo 2018 yo ngan 2022. Ilo mol yignan berkwalo ka nanin kile im kamolol charbal kin aru jipen rain matar eno rojan SPC WHO ego balok pen agency go an UN kap CDC eno chedoro rajaledo kabile ko balok Prainot World Bank toner ro barar collaborating partners tabarakin charbal kin renat por kalabolok ipen ministries national strategic plan go ar lo ar katyong pujen merong lelok ijo mandata iki chen esmur ngan army reinar etcholak chuan enad budalok ijin periberion charabalim karakwan universal health coverage good governance multi-sectoral engagement kap kongo rippin iganan kin ibar kanan claim kaude rolok in multi-sectoral collaboration ilo Marshall Islands emejalik kar lo labolok tabrak ipen NCD coalition NGO go CSO and with campus back wellness center ko wa with me ngano ledok chetian ram rodul gain ko wa cherbal ko roj kamman malikar jen ipen Taiwan Health Center University of Arkansas Medical Science and University of Hawaii. Ibar kanan claim kaude one malak in cherbal gain in chibang gain in local government gain and Melgov Calgov ko wa rodul and Mima Echuan Rollo Chamberang Water Coalition of Willing. Marangong and Cherbale Mini Nai go Ipen Kino and Karigolok Chetia and Abanko. Chejai Gujin one malawat ilo Cherbalin. Emilo Rangain Romanwich, Ijrajang Kum, Ukumun Railok Loair, in Puk Chongo, Ramandada, in Cherbali, Kinchuan Kajuro and Marang Walok, Imalikar. Ilo ami kalabolak wawin pobrai. Abang king jej remalok nganaru par langat lenglok impact wair lo yin lifespan wan NSP nganar marong pobrai chorren gin igi chen wawin gin eno tobacco alcohol kochet. Im kobalok kalbar kagayo lok health system. National strategic planning in a yogadalok and kolak man, iloan emmalak wawin air funny, emmalak opportunities go, and kamban karako iloan prino kamagdi. Kien then a kalimjek what physical measures and not one jongok terrible go yigisian syntax, and kagajor kagian go, and rejected and jongan cherbal gain. It pukien in kia, in kajaraman komoit. Percuanan ilo dan NCT conferencing in Remalong and in Torze National NCT strategic plan in Cherbal gain in Renaj Wallok ilo alik karin Cherbal Goami. Komol tada imani iperu kachuju.
Thank you, Honorable Minister Oda Kuchino. At this moment, I'd like to ask all our participants to please come forward and join us as we take a group photo. May I ask our distinguished guest here to please? Then I'll ask our audience as well to please join us as we take a group photo. Come on. I'll have Jojum join and then group photo yarang. Come on. Okay. Step on our platform here, please.
and what we plan for next year. Just drawing your attention to where RMI is in the Pacific. We're in the middle of the Pacific, the largest ocean. We are also at the end of a long supply chain for pharmaceuticals, medical supplies, supplies of goods and services. This is a very important challenge. RMI is also a very diverse country spread over a large part of the Pacific, which poses a very important geographical challenge for us. And I've also put up our population pyramid. This is based on the 2011 census and projections. But the key thing here is our population is a very young population. So we suffer the burdens of NCD in our middle and older population. The biggest impacts are in individuals in the 60s and 70s. And our aging population, if we do not change the trajectory of risk factor modifications, they have a very, very tough future ahead of them. In 2012, the then President of the Marshall Islands, Honorable Christopher Loak, declared a state of health emergency because of NCDs. PIHOA also signed a state of health emergency because of this. And so as a region, Northern Pacific region, a lot of efforts and resources were put into fighting NCD. We need to ensure that we continue on this, go from strength to strength, and ensure that we mobilize all our resources, including donor support, into fighting this very high burden of NCDs. It is the main contributor of premature deaths in the Marshall Islands. 74% of deaths are attributed directly to NCDs, okay? Most Pacific countries, they lie in the range of between 70, 78%. So NCDs is causing a lot of death in our region. And this is also part of a larger global phenomena, yeah? And it is a very key stressor on our health system and economy. And I cannot understate that fact, that a lot of the pressures that we are facing in our health system now is because of NCD, okay? And the long-term impacts on population developments, sustainable development goals, human development indexes, is prematurely curtailed because of NCDs, okay? Now, what's the burden of NCDs in the Marshall Islands? I'm sure you've all seen this. This is from our 2018 hybrid survey. This is a national representative survey, about 3,000 people, Majuro, Ibai, and I think 3 outer islands. They represent the burden of disease in our entire population. Hypertension or high blood pressure, which is a key determinant or risk factor for strokes, myocardial infarctions. 21% of the surveyed adult population had hypertension. This is pretty high. It's important to note that 68% of those with high blood pressure were never diagnosed prior to this. So this shows the big gap that exists in screening for disease, okay? And for those who had the disease and knew that they had it, how many of them had their symptoms controlled? Only half of them, 51%, okay? So this explains, or at least shows, the big gap that exists in our screening and control programs. For diabetes, it is similar. When screened, 27% of the adult population had diabetes, and another 21% had pre-diabetes. So pre-diabetes have a very high rate of progression to diabetes. So these are very, very high and alarming rates. Gender differences between, for diabetes is very slight. Females slightly more than males. Age distribution, diabetes is more impacting in our elderly population, 45 years and above. But 11.3% of diabetics were diagnosed in young adults, 23 to 33 years of age, okay? The earlier a person gets diagnosed with diabetes, the earlier complications will develop. So this is also a significant finding. Inter-island differences between Majuro, Kwajalein, and the outer islands were very small, around 20 25% prevalences in these surveyed islands. And then the controlled status of individuals who had diabetes. "84% were on medications and not controlled." So a lot of effort is needed in that area. This is a quick snapshot of health-seeking behavior for diabetes and the interaction with the health services. 36% of adults did not have any appointment or have not seen a doctor in the past year. Frequency of self-foot checks. 63% of diabetes have never had a foot assessment. Okay? That, coupled with the poor control rate, may explain why we also have very high rates of amputation. Okay? Blood sugar checks. 42% have never had a sugar check in the past year, which means they had no idea how good or bad their sugar controls were. Okay? Foot checks by a health professional. 69.4% have never seen a doctor specifically for foot care in 2018. And in terms of last eye examination, 53% had never had one in the past years, or never had one previously. We know that diabetic complications of the eye are also leading cause of blindness in our area. And 81% of individuals have not attended any class on diabetic self-management, which is very important for chronic disease control models. Obesity. On the left is the ranking of the 10 Pacific Island countries that actually make up the apex of obesity in the world in children and adolescents. RMI has the highest rate, second highest rate of obesity in younger children and adolescents. Okay? We come second to Nauru. And in terms of obesity in adults, about 65% of our population is either overweight or obese, which is 3/4 of the way up in terms of the world's most obese populations. Now, we want to stress on obesity because obesity has been recognized by WHO as one of the biggest threats to the health of the planet. Okay? Obesity. But why do we have big issues with obesity in the Pacific and in the Marshall Islands? It's a combination of environmental and commercial determinants. Yeah? Food marketing, industry interference, trade-related issues, and the lack of sustainable food systems or food security. Do we have healthy food here in the Marshall Islands, enough for everybody at a reasonable price? As a nation, we need to strive, work with other agencies to ensure that we can have food sustainability, food security for a brighter NCD future. Behavioral factors such as lifestyle, culture, and social norms also play a role, as well as biological factors. Okay? Determinants for demographic determinants of social and economics, poverty and inequity also plays an important role. This year we are having 3 summits, 2 NCD summits and 1 cancer summit. And I'm happy that management in the Ministry of Health has allocated important times for very important health burdens. So a few months ago we had our cancer summit. On the left we have RMI cancer rates. This is for all forms of cancer over the last few years. Fluctuations, generally very high rates of about 100 cases per 100,000 population. 2022 we recorded a big drop in our cancer notification, most likely attributed to the effects of the introduction of COVID into the country. The top 3 causes of death due to cancers is lung, breast, and cervical cancer. Okay? And we have amongst the highest rate of cervical cancer in the world. I'm going to quickly go through some key findings in the hybrid survey. RMI compared to the US, we are much worse than them. But we have significant problems with tobacco use, alcohol use, nutrition in terms of having the recommended meal plan and servings of fruits and vegetables, access to healthcare, oral health, chronic disease conditions such as obesity, diabetes, hypertension, and a lack of cancer screening. Okay? Right now, the next hybrid survey is being done. Okay? Another 3,000 individuals. We will have the results of this survey probably around March next year. I'm sure the results will reflect similar findings as 2018 or a worsening of the situation. Okay? Before we get better, we need to know where we are, right? Okay. This is the indicators that our Ministry of Health collects, and I'm just focusing on the NCD indicators. The white ones will be updated once we have survey results, like the hybrid survey. But the results that we do have, adult mortality due to cancer, adult mortality due to cardiovascular disease, adult mortality due to diabetes, all in the red, okay? Very high rates. We also have significant rates of suicide mortality. So our target is 14 per 10,000. Right now, last year, we're at about 20 per 10,000. So NCD, mental health, suicides, mental health. Dr. Holden usually says there's no health without mental health. It's true for NCDs as well. This is the policy landscape. There's global commitments and recommendations for NCD. WHO has put out a package of aids to help countries, and we'll be hearing presentations from SPC and WHO shortly. There's also Pacific NCD roadmap and other declarations. So the political landscape in terms of policies has been set. This is the MANA dashboard. Now, I won't bore you with the details. Change slide. The MANA dashboard is a Pacific Monitoring Alliance for NCD action. So they're looking at policy landscape. They're looking at important areas that have impacts on NCD rates. RMI is the last country. And the last row, or the last column is actually 2022, 2021 to 22. Green is okay. Red means there's no action. Amber, there's some action. The more stars you have on the green, the much better it is. A speaker which will follow me will have more information on policy landscapes, so I'm not going to go into it. But an area that needs further action, alcohol, the cost of tobacco. Although we have a lot of legislation on tobacco use, tobacco cigarette cost in the Marshall Islands is amongst the cheapest in the Pacific. Okay? And then programs or policies directed at our younger generation, like marketing of breastfeed substitutes, baby-friendly hospital initiatives, and maternity leave and breastfeeding. Policies in those areas have not had any traction in the Marshall Islands. Perhaps this is an area we can address. Keep in mind, the strategy for NCDs should be a womb-to-tomb approach. Okay? Most action directed at reducing primary prevention directed at before risk factors develop. Okay? What's new in 2023? There's a lot to celebrate. Okay? The ministry's strategic plan has been endorsed and is in effect. NCD is noted as a priority area. The establishment of the NCD task force has shown great progression in coordinating national efforts, but we hope for a wider multi-sectorial membership. The NCD Summit and National Strategic Plan Formulation meeting was held mid-year, and we hope to have a national strategic plan come out of this. The decentralization of public health or primary health care on Majuro and the establishment of the zonal system, I think, is key to taking health services to the community. Profiling, house-to-house surveys for Majuro. My colleague Chief Nurse Helia will present on that. The hybrid survey that is in progress. The International NCD Summit, the ROC, I think started 2014 and continues to be a highlight in our calendar. Progress with legislation is encouraging. The public school system meal policy endorsement last week is an important milestone as well. HR capacity building in NCT, the one-stop shop in our hospital, the clinical audits based on quality improvement, and the national cervical cancer policy, which we understand will be endorsed this week. These are milestones for NCD this year. What we look forward to next year, finalization of our national strategic plan and secured funding. Okay? Syntax redirected towards primary healthcare, progress with legislation, redevelopment within the Bureau of Primary Healthcare, trying to strengthen our NCD program, the zonal system enhancement, training of patient care managers to link clinical and community, to enhance clinical and community linkages, cancer palliative care in the community, a primary healthcare system fully rooted in the community, and we hope to open the Ajal Taki Health Center and the Rita Health Center, and ongoing international collaboration to build synergy. So in a nutshell, that's NCD and the RMI, past and future. Thank you very much.
Thank you, Dr. Frank Underwood. At this time, I'd like to welcome through Zoom from SPC, or Secretary of Pacific Community, Dr. Amirita Ravu'u, who is an NCD Policy and Planning Advisor. She shared to us about the SPC regional approach to address NCD and existing support for the RMI. Dr. Amirita, are you there? I'll give this floor to you now.
Good morning and good morning to our distinguished guests and esteemed audience. I've been tasked this morning to provide an overview of the support that the Pacific Community SPC provides in terms of progressing with addressing NCDs in the region and how we are working to bridge gaps in NCDs in the region, as well as just continuing the support that we've been providing to the Department of Commercial Alliance. I think the part of the presentation I want to do is ask just to provide a brief update on the summit. The summit and on what Dr. Frank Underwood has just shared. Next slide, please. So for those of you that might be hearing about Pacific Community SPC for the first time, just to give you an overview, SPC has been at the forefront of development here in the Pacific region since 1940 was established. We have an extensive reach serving 27 member countries and territories. We are also have 9 divisions within SPC that work and contribute to development work in the region. And these are divisions with their focus areas ranging from fisheries to agriculture, climate change, and the ones that you see there on the screen, including a public health division where I am in. Next slide, please. I just wanted to touch base on the programs that the public health division. So we're one of 9 divisions, and the programs that we have under public health and that work in the health domain. So the first is NCD Prevention and Control Program, which I am in. We have our Surveillance and Response Program, that looks at early detections and effective responses to potential health crisis. They monitor disease outbreaks and so forth. We have our Clinical Services Program. They focus on providing support to countries on delivering quality health care and the effective running of clinical facilities and so forth. We also have our Laboratory Services Program that look at strengthening laboratory capacities, particularly to enhance diagnostic accuracy and speed. And then, of course, there's health system strengthening. That is our 5th program within the Public Health Division. But under NCD Prevention and Control, we have 5 key focus areas. And they are the ones that you see there to the right. The first is focused on leadership and governance. The second around capacity and skills and building capacity and skills on NCD prevention and control in the region. The third is around policy and legislation. The fourth around innovation and technology. And the 5th around monitoring and evaluation and accountability. And I'll speak to these a bit in the next few slides. Next, please. So in terms of leadership and governance, the objective of this key focus area for us is to provide support to countries to help our countries in the region to improve NCD political leadership and effective governance. And I think we all acknowledge and recognize that everything rises and falls on leadership. And so this has become a key focus area for us. And the key support that's been extended here is the support we give to countries in their participation in high-level meetings, in convening high-level meetings, be it at the regional or national level, providing support to countries in the development of their NCD strategic plans, in the development and establishment of their multi-sectoral committees. It also involves support around extended to civil society organizations and youth. Now, across the Pacific region, we recognize that there is no significant mass movement advocate on the issues around NCDs. And we see that there are a lot of CSOs that are working, but it's very fragmented. A lot of youths that are also working in their communities, but we are now providing support to bring them into NCD discussions at the national level and to help our ministries of health in implementing a lot of the activities that these groups are very much in touch with the local communities on. In terms of existing support to RMI in this key focus area, it has been providing support to the participation of RMI at the heads of health and at the health ministers' meetings that are convened the HOH annually and the PHMM every 2 years. We've been providing support to the development of the NCD strategy while it's at its early stages. We were there in June for the NCD summit and just helping RMI to facilitate that summit. The third is around the NCD summit, and a part of the support in here as well is not only the technical support that is extended, but as already made known to Secretary Matu and Deputy Secretary Dr. Frank Underwood, there's also a lot of financial support for the implementation of activities that can be driven through the support from SPC. And then, of course, there has been work through one of your key stakeholders, Canvas Back, in engagement of youths in activities over the years. I think since from 2019 to 2023, there's been a lot of support in that as well. Next slide, please. The second key focus area on capacity and skills here, the objective is to build capacity of staff, of community health workers, of all those that are involved in the fight against NCDs to build their capacity and knowledge for effective action. And a lot of the key support here is of SPC through our NCD program. We facilitate trainings, we develop trainings, we support the funding of trainings that need to take place in country, be it NCD risk factor trainings and so forth, as well as the development of resources that can be used for awareness and interventions in country. For RMI, there has been support extended to a number of NCD interventions. I believe in November, RMI is planning to celebrate World Diabetes Day. And so we are going to be providing support to that. There's also, I think, plans for health fair activities coming up that SPC will be providing support to. The hybrid survey, the current one that is undertaken that Dr. Frank alluded to. We've been working in collaboration with PIHOA on that and providing the support to consumables used for the survey, as well as the development of health promoting resources like the ones that you see there in the photograph on the screen. Next, please. And then the third area around policy and legislation. This is a key objective for our program, is to help countries in strengthening public health policy and legislations in all relevant sectors, noting that NCDs is not a health sector issue. It cuts across different sectors, and so we've been providing a lot of support to this, and a lot of the work that's done through the Pacific MANA dashboard updates that all countries, including RMI, do, that Dr. Frank mentioned in his presentation. We're providing support to the development of these policies, to the development of policy briefs, development of regulations, and that countries are in need of developing or reviewing and strengthening, as well as guidelines, health guidelines that are needed. And for RMI, support has been extended to the development of RMI's guidelines for healthy living, using the Pacific Legislative Framework for NCD Regional Good, the PLF. We've been providing support, particularly in RMI's review of the Tobacco Act, as well as RMI's review of the Food Safety Act to include marketing restriction regulations to children. So there's been a lot of support extended in that regard as well. Next, please. The fourth key focus area around innovation and technology. The objective here really is to provide help countries in improving their NCD interventions using innovation and technology, given the move with the digital age. At the moment, we've been working a lot with a number of countries on the development of applications for interventions. And we also have what we call our own in-house, SPC in-house Moodle platform, where we run a lot of trainings that may be virtual trainings that may be requested by countries, as well as webinars and information sessions for countries. RMI in the last 2 years have participated in a lot of our virtual webinars, particularly policy webinars. The Moodle platform is also just an opportunity for distance self-learning, but also self-paced learning, noting that many of us wear a number of different hats, and time is often not on our side for scheduled trainings and scheduled webinars. Next, please. The fifth and final key focus area is to do with monitoring and evaluation. And here the objective is really to establish accountability and mechanisms that can enable our countries and territories to monitor progress of interventions that are implemented, and to evaluate the effectiveness of what's being implemented as well. And one of the key support areas here is the development of MANA, which looks at the monitoring and evaluation of policies, NCD-related policies, not only those that sit in the health sector, but those that sit outside the health sector as well, but have an impact on the NCD indicators that are reflected in MANA. I also wanted to mention here that we are very keen on supporting operational research in country and keen on impact assessment research should countries need this support, particularly because many times we also see that our ministries of health across the region are busy implementing, but when it comes to monitoring and evaluation, that's often a huge gap that's yet to be breached across the region. For RMI more specifically, the support that's been extended is support for the updates of the MANA dashboards. There has been 3 assessments since the establishment of the Pacific MANA framework in 2015. So we've had support extended to update RMI's dashboard in collaboration with PIHOA for 2017 to 2018, 2019 to 2020, and 2021 to 2022. And I mean, we see the benefit of countries monitoring and evaluating through the MANA dashboard. In the case of RMI, this is where they've picked up on all the areas that are in red and that need attention, because these things are not developed yet. The areas that in amber need to be progressed, so it helps us to monitor better. And the Tobacco Act that's under review, as well as the marketing restriction to children regulation that RMI had requested support on, that's in the review of the Food Safety Act, has really are key activities that have come out of the monitoring that's been happening through MANA. So MANA is a very a critical tool, I would say, for MNE in terms of the policy landscape in country. And then, of course, for NCD-related research, RMI is a part of the Pacific Ending Childhood Obesity Network. And for this reason, we've provided support in the past for requests that have come in on RMI's undertaking of BMI profiles of children in elementary schools. So that was back in 2019 to 2020. And because we see how critical this data is, you know, to inform RMI of where they are in terms of childhood obesity. Now, Dr. Frank had mentioned obesity being very critical, and this is another way we've provided support to RMI. Next, please. This is just a slide, I guess, to show that the mandates that we get to do the work that we do and the key focus areas that are now the priority areas of our NCD program and the Public Health Division more broadly are mandates that come through this specific regional health architecture. So through our leaders, when they make commitments at the forum leaders level, down to our Pacific Health ministers at the PHMM level, then of course at the heads of health, and then, of course, with the different forum convenings for directors of clinical services, public health, and our nursing and midwifery. I think this is just to give you a sense of how the key focus areas I just spoke to, none of them are focus areas that were driven by SPC. These all came out of commitments that had been made through the Pacific Regional Health Architecture under which we operate. Next, please. And then I guess just as a gentle reminder here, I mean, for those of you that have been in the NCD space long enough, we do know that a whole of government and a whole of society approach is needed when we talk about addressing and bridging the gap of the NCD burdens. Again, I think it's just important to reiterate that the causation pathway, you know, for NCDs, research has shown that at least 80% of what's contributing to the end product, that is the NCDs, is really at the upper end of the pathway, and it really has to do with, you know, commercial and socio-economic determinants and so forth. So it's really beyond the health sector. And again, I think in the summit discussions that happened earlier in June this year, There was a lot of discussion around so many things that are happening as well outside the health sector, but I guess as a way forward, we need to map these out and see how we can leverage on these partnerships and complement what's already happening outside and beyond the health sector. And I guess just to stress, the health sector, we can take lead in some aspects, but many of the interventions, they do require collaborative actions beyond the health sector. In these sectors that sit outside health. Next slide, please. And this is my final slide for this part of the presentation. Again, just to reiterate here that when we talk about bridging the gap and addressing the NCD burden effectively, we need to be thinking more outside of what happens outside of the health sector. We need to be thinking about changing the environment, and changing the environment means changing a lot of those things that sit outside of health. Individual behavior change, if you change the gradient, and if you change, invest more in changes in the environment, it will make it easier to change behavior. But if you look to the picture on the left, if you don't invest in changes in the environment, but you're focusing a lot on devolving that responsibility to individuals, or just focusing on the clinical parts of the NCD causation pathway, the gradient is very steep and it's harder to get the change or to bridge the gaps that we hope to see changes in. Thank you. I think that brings me to the end of that part of the presentation. And so this is just my concluding slide, just to say that we need to be tap turners, turning off the tap at the source, that strong action is needed, but needed beyond the health sector, and not to be floor moppers. I think as we've seen since the declaration of NCDs as a crisis in the region in 2011, there's a lot of activities that are very, that are focused on the clinical components of NCDs, rather than focusing on the other determinants of NCDs that sit outside of health. And that brings me to the end of that presentation. That was just a snapshot of the support that we provide and can continue to provide to our countries in the region, including RMI, in efforts to bridge the gap on NCDs and addressing and combating it effectively. Thank you. And I guess the second part to it is just to, I guess, speak a bit to the summit, the NCD summit that was held back on the 22nd and 23rd of June. And I guess very quickly, I just want to mention here some of the key findings and the insights from that and the recommendations on the way forward. And I note from Dr. Frank's presentation that 3 key ones have already been progressed since that meeting. And I think it's always good as well to just share on these achievements, because many times we focus a lot on the NCD burdens, and it can tend to be a pessimistic way of looking at combating NCDs. So just on some of the major things and takeaways from the workshop, I think it was very clear in the summit that the need for collaboration, and stakeholders that were present talked about collaboration, but also coordination. So much is happening, but how can we coordinate it better? There was also a lot of discussions around policies that are already there, but the need to improve on enforcement of legislations. Again, enforcement remains a huge gap across the region, and I guess for RMI's information, and this is also an area through our policy key focus area, we're trying to provide support to countries in convening enforcement workshops across with those who are enforcing authorities, including the police, or if we're talking about alcohol indicators for countries that have land transport authorities or road authorities, that they are also included in those discussions. There was a lot of ideas and strategies, around, there was a lot of discussions around leveraging existing programs and resources, and I think this is why, as a way forward, and this is an area we are keen to support RMI with is in mapping out stakeholders that are already working in the NCD space, not only in the health sector, but beyond the health sector as well in your other ministries. And this is, in my view, in the view of our program, it would greatly benefit the development and the resourcing of the NCD strategic plan is if we have a landscape view and a holistic view of the actors that are already there, and to be very clear on what each one is doing and how we can complement each other and leverage partnerships. There are a number of areas of concern that were also identified. There was discussions about shortcomings in leadership, HR, communication, the need for more healthcare training, the need for more health promotions to increase awareness, the need to look into technology and digital health. A lot of it really are recurring issues. They're not new. Again, it was well recognized at the summit that addressing these require concerted efforts and collaboration and just improved coordination. And so, based on the findings and based on the discussions that took place at the summit, it's pleasing to hear from Dr. Frank that an NCD committee has been established, although wider membership is required. And I think that's a huge milestone because it's not an easy thing to do, particularly if we're having to look beyond health to involve other sectors in the membership. Moving forward, the NCD program at SPC will be providing support to the follow-up consultation meetings that will need to happen with stakeholders once we've ironed out some discussions that we need to have with Dr. Frank and the team on progressing the development of the new plan. Noting that the vision, the mission, and the strategic objectives, there haven't been any significant changes to those, as was agreed at the summit. But I think one of the things that's clear from the summit, RMI wants to take on a more systems approach and look at health system strengthening across the board. And so one of the key tasks we are hoping to do next and planning to do next is to look at the activities that are in the current plan, those that have been implemented, to what extent, those that have not been implemented, how do they fit in that systems approach, and then discuss on finalizing that with the RMI team. I think that's all from my end. Thank you.
Thank you, SPC Dr. Amirita Rabu, for the presentation. I'd like to call now Public Health Chief Nurse Ilya Enos to present to us Major Screening and Profiling Data Analysis Report.
Media, can you stand and press, please? And ang tayong secretary of British dress is like in city. You missed it. Thank you. Superintendent Song Hospital. Delegation from Taiwan. Secretary of Health. Deputy Secretary of Primary Health Care. And Acting Deputy Secretary of Police, DPS. Chief of Staff. Chief Secretary. Who's and all the doctors, nurses, ladies and gentlemen. It is a great honor to be here to introduce the profiling, which is the first time we're doing it in RMI. is the first of its kind. This one was held by a collaborative number of stakeholders to create and generate a framework that supports community health profiling. Next. The objective to identify individuals that are falling through the crack of RMI, MOHSS, healthcare service, and active case funding to fill up the registry for a target approach with decentralized of healthcare service. So we want to decentralize all the data into the MA system in the hospital. Public health leads pointed out that needs for case finding. Actually, we, not me, but we plan to have the idea to start on the profiling in 2019. However, due to the COVID-19, it altered our project until this year. And public health nurses, Amy and Lorraine, I want to thank them to create the community health profile template and questionnaire combining the needs and data needed. And it was also included some of our staffs. We sit together and try to make some changes to a new one. And that's where Taiwan Health Center stepped up to the need and supported the project by making the whole process digital accessible. And a big appreciation to Chung Hospital to contribute the digital equipment, tablets, health box, which contain all these equipment inside the health box. And also to WHO, who accepted the project proposal and supported the project financially. So thank you, WHO. The task force team, which consists of the director or the deputy secretary of primary health care, chief nurse. Sorry, can you hear me back there? No? Okay, sorry. So the task force consists of the primary health care director, chief nurse epidemiologist, consultant, Dr. Duran, Taiwan Health Center, public health consultants, and NP Taina. Thank you, Taina. And finance requested to WHO, and it's called TFC, and it was accepted and approved. So there were 8 groups were formulated. We call them caregivers, and they are the nurses and the JAWs, and they are the very hardworking. They do all the works in the outfield. Can you give them a hand, big hand? Profiling team, stand up. Stand up so everybody can see you, all the profiling team. Okay. Thank you. So the project was launched in July 17 by the president of the HE ambassador, Steve Chu, along with the minister and the secretary and some of the program manager, directors, nurses, and all other programs. And the training took 2 days to train all the staffs. And the project commenced by going to house to interview and collect all the data by using all the useful tools that was donated by the Chung Hospital. So these are some of the actions. Actions speak louder than words. So during the launching, they were happy. They were smiling. Even it was in the newspaper. And some of the nurses were appreciated by the community because they never see anybody going there to check all the household, the vital sign. And some of them were fallen to the crack. They never come to the hospital, and they were treated on site. They were referred to emergency as well to the other clinics. And these are the trainings. And this is the first day of the launching of the going house to house. They were so happy. And these are the kind of donation tools from the Chong Hospital. It contains the health box, which has the blood pressure cuff, and also including along with the glucose stick and also scale and tablet. So all the data were analyzed into the tablet with the TuckLoop apps from the Chanchen. So by going house to house, that's how do they do. They measure all the household. Even they do the health education to the people. And some of them, like HIV case, they also treated the toe infection. And some of the homebound patients with the wound care, they also treated at home. And this lady here, Pubu, from Namarix, is very happy because she doesn't have a time to go to hospital, but she was seen by NP Tainai and some of the staffs, and she was treated at home. So here, the environment, some of the water catchment with the rubbish scattered around, and the house living. After profiling every day, they come back and report. So we collect all the data every single day. And you see the chart down here, the green means complete, the house is complete. And the yellow means it needs to go back because some people are work at school. And red means totally no people at home. So some of the data here from Rita to the hand of Dalab, the Mormon Dalab, that's from June 1 to 3. Here in Metro, we have 6 zones, and we are now in zone 4. So we are almost there. So we've seen 2,395 people so far. And before going to zone, we have to see the report. How many people they have seen, how many people mean that they're in the system, but there's no vital sign. Because, we have encountered some technical problem in the apps, so it was fixed by the IT and Johnson. And these are the age distribution. And it seems that 19 to 40 years has the number of age group here. 65 years old is 145, and 41 to 64 is 603, 19 to 40 is 754, 6 year to 18, 604, but we need to have some more data here. And we also looking the kids who are vaccinated or not vaccinated. Some kids are still in our system, way by sea, that we cannot find them. And only few, like 79% are completed, and 21% need to come back to get their vaccination to complete. For the NCD case management, diabetes for female has more diabetic than male. And there's also a lot of dual potential. Potential means those who never know that they have diabetes, they never know that they have hypertension. But from this health profiling, we're able to find them, to treat them right away and refer them. And I think Dr. Kyle and Dr. Jean have seen a lot of them coming to the clinic because they've been telling us, we see a lot of cases coming from the community health profile. We have some challenges so far. Vehicle. Every day we have to look for vehicles. Sometimes They were on the field, and the program called them, oh, we have to go to lunch. We need a vehicle. Oh, we have, like that. But we need more vehicles. And even shine on rain, the profile team, they go out field. They use umbrellas to shield the dogs. So in concluding, I would like to, on behalf of the Ministry of Health, the profiling team, RMI people, I would like to convey a sincere komoltada to World Health Organization for the funding to support us, and also to Shanghai Hospital and Ambassador Steve Sia, Honorable Otakisino, Minister of Health, Secretary Francine, and the task force group, and especially the profiling teams. Thank you so much.
Thank you, Chief Nurse Ilya. Can we give another round of applause for our team? At this time, I'd like to have our panel discussion for Q&A for our presenters. So if you have any questions, the floor is open now to everyone, including our participants online, for our presenters. Are there any questions? You can raise your hand. Okay, we have some hands that are raised at the back. Do we have a microphone for them?
Yakoy, marami rong. Iba marami rong.
Emman, we can hear you. Can you please stand up so they can see you, please? Okay, Emman, Cholopur. Go ahead.
Well, Mother, Yakoy Olip, Kamodol, Secretary of Rudaran Ministry, Ganami Angar, Jujim Alaway of Creo, and I am Chief Secretary Kobata Loyan Puebanado in Lamana Lamana Auruk, and Regidat, Julian, Mulin Gorono Koralap, Alalinara. Kami yang cala yang kita kan rekal kerja kerja yang matan jadi mata lalu ko ilo pelagi lalu mereka lead ilo NCD kita non-communicable disease ini ngaji baca cici meroja ke presentation wajan cara kanan public dalam haram rojan ingat ya SPC ya dan cara kanan ingat aku I guess my question really is, this is a national initiative that involves the entire government. Not only the government, but it also involves state-owned enterprises, civil society, and other key stakeholders that are also responsible for carrying out and implementing health-related issues, basically in assisting the Ministry of Health to promote health all throughout the country. And I'm just sitting here and asking colleagues around my table whether or not invitation was extended to others. And it seems like this is only the Ministry of Health, if I'm correct. But like I said, this is a national initiative that requires the full attention, support, and cooperation of other key stakeholders, including the Ministry of Health, PSS, NRC, finance, and other key stakeholders. And it's important that we're discussing these issues among Ministry of Health people. But you guys already know these issues. Why not extend the invitation to involve others, for us to hear information and also to share our experiences or our inputs and how best we can, as a nation, address these grave concern. I myself, I am a disabled person, and I suspect this is a result of my own behavior, my own attitude. I did not see the need to then actively visit the clinics. And as an end result, this is what I have become. And I'm a living proof of Jono me chep lukullo auragan ta kete para ko nuran. I don't see disabilities here. Royal Disabled Organization. Ang ayalam na ganoon auro ba kaya nagar kada pa kri secretary ang rota lagu organ kay iwar pulen bar melo lagu ramarong ordo ko kada pa balok ilo arwi. Ekonogan binigay mi roja dal linar. Eje mi uran linar. Aro chimoro ro na dami ang itong palo. Ekonogan kami yung radio program kami im ngayar bar kanan bar lalegar tira kanare ngai igran jala iloan ludo ko chen ko rala igi federal program ko ako chen ko jin beri do jen channel fonare yorge wo da lo jenaba ejige rigolok NCD lo majali ejige rigolok tangal high blood cancer mino ko yalla ko emelang ejap ebajit kain be jangan lukun connect ngayon jangan ekonomi food security kalau mereka orang punya perperaran tinggi aku nasi ini kayak ekonomi chat policy ko me pernah cipang magi kemanar chicken galu jadi ekonomi baik we elang burit orang kaki ini ko mereka kabiruan regal libro kada ki bridge ko ayam biaga ki merong mayer raini ni laboda rang potok len wuji gejan ligin majo e bayit kena ka jicep e supply ko ipen farmer warang man supply gitu temen ilo mun wi ako imi mun mangay ko muj kay ni ame adangan ala da muya mangay kami ay jolo kanangin limong ujiman talang ano cicuot pesto ko ako nilugo gain me ramban ngan yajmi ur ijaji parko war policy ngan karilo ngonen wud milo ko ako mga wame rene ngan ngecep rutangalo da rutoro itong ngan cara lagu yun jaji lange ebelo policy wan education impumi juga collaborative in education ngan dorilo curriculum ko parijiguro ran nakatak chen kindergarten lingolong ora garilo lukila chunguro chen mero meriyo nur koy eji muro men koy la ko em ko mana jujum jolo ko buru ngai ijare cibiru kemelo lagi na ngai baj pero ci mro ya gam oda bai kamolol secretary ga nam gar Allah ko kure ko bijan chief secretary kana men ko ba ko bulan to ko ngai balang kain forum lagi wi la mara ngai jawro ngai jeng kuru to project madare elang areng national security plan ko medang lalim pillar ko lawan muji lamra ka para oro ko ngar ko ba do chairperson ran pillar rin ka chuju we tolo balang ko na rilo cara balingina dil ma ga jumur ko mala wa jumur plagin ma jam o genar gen riro perkaru mi chibilo pache kulguna mol da em cara ma ko ma lo forum ina
Thank you for that question and comments that were very insightful. This actually marks the second NCD conference we've had this year. The first was in June. For both conferences, the organizing committee echoes the same sentiments as you have, that multi-sectoral collaboration, whole of government and all of community response is needed. Unfortunately now and also in June, participation from other stakeholders was limited. The organizing committee also sent out invitations to the whole of government, NGOs, some NGOs, civil society organizations, as well as local governments. From the Ministry of Health side, we had to take measures to ensure that most of our clinicians and staff involved in NCD, public health, and the key clinical stakeholders would attend. So we allowed them to come and participate. More work needs to be done to ensure that the whole of government and whole of society participates in NCD planning and responses. The NCD strategic plan which has been developed will need to be validated, and that's working with SPC. In that validation, we would like to ensure that all secretaries in government, all leaders in local government and in communities, as well as civil societies, including people with disabilities, attend, because the implications for everybody is huge. Secondly, we like to secure more funding for our NCD strategic plan and responses, and part of that accountability for funding is participation. So fully agree and look forward to more participation from the whole of society. The organizers also took measures to try and make these presentations more accessible to the general public by having NTA live streaming of the event, as well as allowing participants to join via Zoom. And we hope that more people will tune in, replay parts of the presentation, and also put forward their views. Thank you very much. Oh, the second part of the question on statistics, I had presented on what we call the hybrid survey in 2018. The next survey is being done right now. So that'll be the most up-to-date data on health status of our population in relation to NCDs. So we are hoping that in March, that information will come out and will be widely distributed as well. Yeah? I hope that answers some of your questions, but fully agree with the sentiments and comments you made. Yep. Secretary for Health, additional comments?
Thank you, DCS Richard, for providing your insight. And these are some of the things that we're always discussing. More importantly, we acknowledge your presence and being with us today. So, kumwal. To Dr. Amarita, thank you so much for the presentation. What you have outlined is exactly what we had noted in our last meeting, as Dr. Frank mentioned also in his presentation, that we would be going forward. There are some areas that we need to work on in terms of validation, and I believe we're looking at some data that is coming forward with some of the profiling team as well as MIAPI that can also make some changes to what we had endorsed previously. And it's good to have the support of SBC. I know you mentioned the ECHO and the other programs, and I think it's about time that we really enhance the partnership between SBC and the NCD program in the whole of RMI. There are areas that we see that could be duplicative between WHO and SBC and other partners. So I'm hoping that we can have some time to ensure that these efforts are not duplicated but are complementary towards each other. For Dr. Frank's presentation, I just want to applaud you for really bringing us to the forefront of the accomplishments. Yes, there are some challenges that we face in the last 5 years that we've been working a lot in getting the plan in place. But it's also important to acknowledge the strides and the accomplishments that we've made today. And then recently, there was an email circulation about the public school system. and their endorsement of the policy with nutrition and the family education. So this is very important to know because we've been asking the PSs for many years to include this in their curriculum, and finally it's now in place. So congratulations to PSs on this accomplishment. For Chief Nurse Celia, thank you so much. That was a very enlightening presentation. I also want to acknowledge all the work that you guys do despite the challenges that you've shared with us. Please know that we will continue to support the program, and I understand that we're almost halfway, and I would highly recommend the team to really advise on what the programmatic and operational funding gaps are so we can ensure that it's provided on a timely manner. Come on.
Madam M.
Are there any more questions? Okay, NP Taina,
No.
go ahead.
Yakwe. Yakwe. Closer. Thank you. Just a question for the compiling, since there was a great question on the budgeted of medication towards the compiling team. I wonder if anything has been set aside for that. Thank you.
That's a very good question, NP Taina. Two comments on that. We have discussed this at our senior leadership or ministers leadership team level, because one of the biggest barriers in people coming for care has been identified as cost. The $5 cost for medications can be prohibitive for a lot of people, and that's been echoed by the profiling team as well as the University of Arkansas Medical School surveys with faith-based organizations. So we've discussed, and we have some options that we have put into cabinet. Number one, the removal of fees for hospital consultation for individuals who are senior citizens. Or number two, all fees associated with NCD care. However, keep in mind that the proceeds of these funds go towards our pool of funds that we buy medications, tests, and other equipment for the delivery of health care. So the ask is we supplement these funds, if we are going to do that, probably from budget provisions in the new compact funding. So that is something that we have planning long term. Medium term, the profiling and house visits is not a one-off thing. The zoning system means healthcare is delivered in the community on a daily basis. So in time, we will have a provision of medications for free in the community. But in terms of procurement supply management, we have to ensure that we have enough in our system coming in and going out. So that takes a bit of adjustment. So we'll have to account for the numbers of medications needed in the communities. So it might take up to 6 months before we get that adjusted. So those concerns were heard, and there are medium to long-term solutions on the way. In the meantime, we can encourage our patients to get their medications refilled. We can try and talk about the importance of compliance with medications and good control, encourage them to get their medications filled at the hospital. And for those who need emergency care, we can continue to navigate them through the system. I hope that answers your question.
Thank you, sir.
Yep. Thank you.
There's another question. As for the zone nurses, they are really going out And I know they're looking forward. They have their population, especially for zone 1 to 4. The only thing I'm asking whether the infrastructure is ready for them. Yeah, that is it.
That's another good question. Part of the zonal system is trying to find a health center to locate the staff. Laura is our only health center with Wacha as a clinic. Okay. Ajal Taki Health Center is about 90% completed. We hope to get that operational in 2024. The Rita Health Center at the Janrock site, there's been no shovel in the ground, though it's in the plans. We also need that facility operational, hopefully in 2024, and ideally before the Micronesian Games is staged. So that will take care of a few of our zone teams. Other teams may be based at the hospital and go and provide services in the community, operate clinics without walls, working with other stakeholders like faith-based organizations to see if churches can function as clinic on certain days. But we work with what we have and we try and build on that. And we hope to get those health centers operational soon. Yep.
Thank you, Dr. Frank.
Are there any more questions before we go to our lunch break? Okay. Before we have our lunch break, I'd like to ask Regagi Piwis to please bless our food before we eat. Come on.
Mulimsi, cuci bercer, kami bercer pelak tu ngani ko ani jala balap, elegna am garrong jagi, nana ko ramman ka bercicet, elam ko boy perro ngana am tari naigi, nangli biju gini mer recep kabu, agak bercilet murgina, moga jana mon malok yang kagajur, kemudian pujar kajini meriba jangan yuk kacida kan kanin cita bam, kemudian boy am mangai perro, ngajar, oleh boy win kan pewajan pergi lo yenin. Kemana pun mangagin renan utuhin akpa itu men ngan murga nama yang rilam car molot amen.
So everyone, it's time for our lunch break. Our lunch is there at the back. Please be back by 1:15 to begin our afternoon program. more on dialysis. Thank you.
Hello, good afternoon, Yakwek. I'm Dr. Liao. This is my second year. So last year, I think we have the gorgeous meeting of the after action review, right? It's the COVID-19. We talk about the post-COVID conditions. This symposium is about the NCD, and I would like to share some of the probably the knowledge and sorry, okay. Yeah, is that, can you hear me? Is okay? Okay. So I'm going to talk about dialysis. So I think the dialysis now globally, they have the quite variations. So some countries actually have the providing the dialysis. Some countries still not yet. So, but for the kidney failure, we face these options when the kidney shut down or the kidney gradually lost their functions. Dialysis is the options to provide the life saving, all right? Okay, so this is the International Society of Nephrology. Every year they publish the global data. It's called the Global Kidney Health Atlas. So they're showing the global data, showing this, so next, so can you full screen? Use the full screen, yeah, please. Next, yes, okay. So this is from the International Society of Nephrologists. Every year they publish the epidemiology, the status, the state data showing that the current status of the people under kidney disease or they receiving dialysis. So if you look at the data, it's over 850 million of the worldwide population now have the CKD. And after that, 0.1%, they have the kidney failure. So it's quite a lot of the population actually have the kidney disease problem, okay? And nearly this 4 million people now receiving dialysis or kidney transplantations. But this just represented about 25% of people. They do need the dialysis, they do need the treatment, which means that about 3/4 of patients, 3/4 of the patients actually, they do not have access to the dialysis or transplantations, okay. So this is the global distribution. I think, next please. There's 2 arrows, right? One is the Taiwan, it's just nearby the China, and the one is the square is the Marshall Island. The color is showing their density, the population of the CKD burden. So you see that the dark blue one is the highest burden. So Taiwan is actually the highest burden of the kidney disease. So I will show you this, the Taiwan, that's why the Taiwan is the number one, the top 1 countries with actually receiving dialysis, okay. But Marshall Islands, I think RMI is in the middle. The burden is in the middle. Okay, so considering the epidemiology by 2040, CKD will estimate become the 5th leading cause of the death. Okay, so it's quite largest projected increase. The reason is the increasing prevalence of the CKDs because they are aging. And this is particularly important in the high-income countries. They're aging, they're getting older, and they have the higher chance to get into the CKD end stage. To become the dialysis, okay. And the people also have the obesity, diabetics, and the hypertension. They have a high risk of become the CKD. So this is in Taiwan, and I think the same in the RNY, the obesity, diabetics, and hypertension, always the high risk factors that contribute the CKD prevalence. And for the kidney disease, we know that the etiology has many etiology, but diabetes is still the number 1. I think it's here and of course in Taiwan as well. And also other diseases like hypertension, glomerulonephritis, or here maybe you have some of the stone or repeat infections. They're not being treated properly or even been treated, but repeat infection also cause the kidney damage. But a lot of patients actually, they have unknown the etiology of the kidney. What happened to their kidney functions loss? We don't know. So we need to do some, we call the kidney biopsy. So we did quite a lot of kidney biopsy to understand what happened in the kidney. Yeah. So this is the cartoon showing that when you have the normal kidney, you will have the good size of kidney, right? Very reddish, yeah. And the microscopically, you can see the very good structure. But once your kidney get damaged, the gradually lost your kidney function. The main kidney function is excrete your uremic toxin, waste product, and the urine, right? So it's two components. So once you get your kidney injury, damage, gradually lost your kidney size will shrinkage, right? Like your right-hand side, shrinkage. And your kidney will lose their functions. So your uremia toxin will accumulate in your body, and you will become edema, swelling, because your urine will getting less and less. So that causes the problem of a lot of the symptoms develop. But the problem of the CKD, we have the different stage. Not until very late stage, you don't have the many obvious symptoms. So that's the very tricky things and very dangerous things, because people don't know that. They say it's okay. Because yesterday morning I went to a community, because I find there's a patient with the stage 5, very end stage. He's a young adult, young man. But I find he is still not quite awareness. He still not have many symptoms. Next, please. Sorry. Well, so the symptoms include they have the metabolic acidosis, dyslipidemia, hyperkalemia, and a lot of the uremic symptoms. They will have some of the nausea, anorexia. They don't have the very poor appetite, and they will have some of the tremor, and also they have some of the conscious change. They have the anemia. They feel fatigued, tired. So in that case, sometimes people just come into my clinic. They're actually not quite obvious symptoms. They just feel tired and feel poor appetite and nausea, vomiting, and they do the blood test and showing, oh, your data has very bad. You have the creatinine, your renal functions decline quite quick. So in that case, refer to me as a nephrologist. So sometimes it's very late. So this is the one thing that's about awareness. So awareness of you have the kidney disease is very important. I think it's a very fundamental issue to understand that you have the kidney disease. You need to take some action to avoid they become the kidney failure. But one thing that if you end up with the end-stage kidney failure, there's nothing you can do. You need to do some of we call the kidney replacement therapy. The so-called kidney replacement therapy, I think it is slightly misleading, because it's not totally replacing. It actually is supporting. Not like only the replacement is the kidney transplant, because kidney transplant is using the new kidney to have in the patient. So that is actually replacement. But for the dialysis, is just a support, because you see that the dialysis can only do the 10 to 15%. So you still, once you get the dialysis, you still have the CKD. It didn't recover. But if you get the transplant, it's more than 50%. Basically, you can do in like normal individuals, okay, once you get transplant. But for the dialysis, you can only replace 10 to 15%. And this is very important, because dialysis didn't cure your disease. Okay, it just maintains a kind of the mechanical surviving, yeah, but this is not very good quality of surviving. So just keep in mind that, yeah. So transplant still is the best options for this kind of if you have the end-stage kidney failure. It's cost-effective and with the best clinical outcome. And what about the other choice? If you don't do the transplant or do the dialysis, the only way you can do is a conservative management, which means that you can use the medical treatment as best as you can to prolong their survival. But this is very challenging, because it's very difficult. People still, because you know that once you get failure, you don't have the urine, you don't have the ability to excrete your toxins, then you will die. Yeah. So this is the comparison of dialysis and transplantation. So dialysis is life-sustaining, and you don't have to change the treatment. But the problem is that you take many hours on dialysis. For the hemodialysis, normally you have to take 3 times a week. Each time that you spend like 3 to 4 hours, stay on the bed in the hospital or in the clinic. Yeah. But if you get the transplant, either it's a donor transplant or a living donor or deceased donor, you can do the happy life. But you need to take some of the immunosuppressant drug for lifelong. But nowadays, I think this drug is more cheaper and also more effective. Okay, so for the dialysis, you have 2 options. The main 2 options, you have the hemodialysis and the peritoneal dialysis. So every country, they have a different proportion distributed based on their generally based on their government policies and their disease, the geography, the variations. So for the hemodialysis, you use your hand, mostly your arm. You do the AV fistula, and you have the puncture, you have the needle to connecting the, we call this artificial kidney. So doing that, your waste product and your water in your water load can be eliminated from this machine. For the peritoneal dialysis, you actually use your peritoneal membrane. So you don't have the artificial kidney. You just use your own membrane. So you instill some of the fresh water, fresh fluid, go into your abdomen, right? And then they replace it and coming out. And your water and your uremic toxin will go out like this way. So this is by nature, okay? So there's 2 ways. But the 2 ways currently, if you look at the survival data, actually it's not quite different, but every country has a slightly different. But overall, you will see that by age, you will see that the 40 young adult, you still have the expected, if you have the kidney failure under dialysis, right? Your expected year lifespan still quite shortened compared to the normal individual. Like you have the 10 years. So if you are 40 to 44, right? But if you are 70, let's say that 70, you only have the 5-year survival rate. Survival can survive them. So this is based on this. And this is a problem of you need to think about every country, every government need to think about their population. For example, in Taiwan, because the aging population, so aging population, their survival, the expected, if you on dialysis, can be like less than 5 years. And that will cost a lot of the money, of the budget, right? So is that worse or not? So nowadays, in people older than 80 or 75, there's something that the policy is a little bit changed, trying to move to more conservative management, not pursuing the dialysis in the elderly, very elderly, because there's no point to that, yes, because for the survival consideration. So for hemodialysis now is still the most common is the KRT, the kidney replacement therapy. So overall it's account like 70%, and of the dialysis is about 90%. In Taiwan is similar, 90% is under hemodialysis, roughly. Okay. But in the problem is in some of the areas, especially the disadvantaged populations, they may not have the accessibility to the hemodialysis. And one of the problems of the dialysis patients, they still have the cardiovascular disease. They normally die from the cardiovascular disease. The second is the infectious disease. Okay. So, like I say, the dialysis still replaced 10 to 15% of your normal kidney function. So you still have a lot of the burden of the symptoms. Next, please. So this is altogether is the people under hemodialysis. So you still have a lot of the problem come with you. So it's not cure. So this is why the quality of life of the people under dialysis is still not very good. And the doctor need to doctor and the nurses still need to take very good care of the patients, because the patient has a lot of the symptoms. You can consider they still have the cramp, anxiety, they have the itching, they also have some of the sexual dysfunction, nausea, vomiting. This anemia, this also still there. They're still there. You still need a lot of the medications. So one of the burden of the dialysis patient is not just the dialysis, the cost, but also the medications cost. So some country, as far as I know, the government provide the cost for the dialysis, but not provide for the medications. So that's still a lot of the cost, because they need to manage all these symptoms. They're still there. They're still there, okay? So that's the problem you need to understand. And for the peritoneal dialysis, I think it's the symptom is probably similar to the hemodialysis. There's some evidence showing there is a convenience at home treatment and improves a bit the quality of life, especially in the young adults. Because young adults, they need to go to work, right, during the daytimes. And if you receive the hemodialysis, you basically bound to the hospital. You need to visit the hospital, stay there for 3 to 4 hours, 3 times a week. But if you do the peritonitis, you can actually freely to walk during the daytime. I have a lot of patients using the peritoneal dialysis. They are young adults, they walk during the daytime, so they can freely do that. They do their dialysis at home at the night, yeah. So technically it's simple, but still needs some training, okay. It's cost effective in most countries, sometimes, and in some resource limited, you can start to do the peritoneal dialysis first and gradually transition to the hemodialysis, or both, or do the dual, okay. Okay, this is the US RDS, this is the United States. Every year they have the report from the kidney disease globally, and they do the international comparison. So Taiwan continues the top 1. So you see the top 1, Taiwan is the top 1. So currently around 90,000 patients in Taiwan is end-stage renal kidney disease. So it's a huge, huge population. And of them, only 4 to 5% receiving renal transplant. Why? Because the donation is not very high, right? Okay. And now we encourage to do the living donor. I mean the relative, your mom, your dad, or your sibling, right? And that would be, but that's still quite limited, because so there's like 5%. And the majority, as I mentioned, is near 90% is still under hemodialysis. So Dr. Maxson visited my hospital. You see that the whole room is the patient stay there on the bed doing the hemodialysis. It's terrible, right? Okay. So you will see that this is quite a lot of patients under dialysis in Taiwan. And the peritoneal dialysis is roughly 10%. But from this year, Taiwan's government is trying to promote the peritoneal dialysis, because I think the cost is the problem. Like this is the figure is showing the cost. This is counted by per patients per year. So in Taiwan, for the HT patient, hemodialysis patient is $20,000 US, roughly. And for the PD patient is like less than, as you see, it's quite dramatic. It's 3,000 roughly, yeah. And for transplant is unique. The first year is the most costly because the surgery is quite expensive. But after the first year that they survive, they only need to take some medicine or immunosuppressant. So the price is going down. So this is why the transplant is still the best way we need to promote. And as I say, the outcome is the best. Okay. And this is the next, please. And this is the global projection. So we are now is 2023, right? So it's just in the middle of so you see that currently is roughly 4 million people receiving dialysis globally. But it's just like slightly around more than the 10 million people actually need dialysis, need treatment. But only there's the 4 million receive them. So it's like 1/4, yeah. But by the end of the 2030, right? So you will reach near the 5.4 million people receiving dialysis. But the total population need dialysis or treatment is 14.5 million. So this globally, actually, they are all increased. So this is the prevalence will increase. So this kind of the issue still getting a huge burden in many countries, like in Taiwan. So how about the sustainability? So because we do the dialysis, hemodialysis, we use a lot of the water, right? So they're using the water to actually to clean up your blood. So the water, every time you use a lot of the water. So for one session of the water, the dialysis, you use up the 400 to 500 liter of the water. So this is quite a lot. So considering if you have the dialysis unit, you have 30 patients under dialysis, for the whole year, that unit will spend about 4 to 5 million water. So the water is kind of the consumption is quite heavy. And also the energy waste, because the machine need the energy. But also some of the plastic waste, the tubing, the plastic bag for this water or something. So to be more sustainable, I think it's the dialysis is not need to face a very big challenge. So nowadays we think about how to reuse or reduce and recycling this part of because it's not sustainable. It's not sustainable. So even if it's RMI have the dialysis unit, need to consider this kind of thing in advance, whether to actually can reuse this water and reduce this some of the waste. Okay. And this is the final slide. I just quickly summarize that this one. So like I say, dialysis is not a good option, honestly. It's life-saving, but it's not perfect. And we need to consider the ecosystem of dialysis care. So from the patient's viewpoint, I think the prevention is still very important. So early detections, early management of this CKD, the kidney disease. So let them delay their process to go into the dialysis requirement. I think this is most important. And then the government also, the society need to have a proper plan about this kind of the supporting, how do we gonna reach the dialysis, providing this service. And because this is quite complicated. As I mentioned, this once it starts, it never ends, and the cost is increased, okay? But so we considering that we need to consider the low-cost options and also trying to see the more green way, okay, green nephrologists, and trying to see how this works to improve the patient's life quality. So like I say, dialysis is just dialysis. You still need to management their symptoms. There are a lot of the complications associated with the kidney failure. So there's a little bit complicated, but this is need the whole team's work to care the patients. Otherwise, the diagnosis will not work. Yeah. Okay, thank you for your attention.
Thank you, Dr. Chia T. Liao. May I now call upon Dr. Kyle Lamari from our Midgetto Hospital NCD Clinic to present to us on our NCD Clinic one-stop shop services.
Can you guys hear me? So, good afternoon. My name is Kyle Amari, and I'll be updating us on the one-stop shop that is currently ran in the NCD clinic. So the concept of the one-stop shop is to integrate all the needed services for NCD patients into one place. This is not a new approach to patient care, and it has been used before in prior years by the NCD collaborative teams with great success. Although it is not a new concept, it was really recently reintroduced back into the SOPD clinic. Next slide. So In the last 2 months, there were 3 services that have been recently added to the SOPD clinic. These are eye exam, food exam, and point of care HbA1c testing. I'll elaborate more on these 3 later on in the presentation. Although there's only 3 that have been recently added, there are still a lot more services that still need to be added to the NCD clinic. And to name a few, dental care, depression screening, cancer, TB screening, and these are only few, then there's a lot more. And we hope to integrate more of these services in the near future. If you've ever been to the hospital as a patient, as an NCD patient, or as an attendant for patient with NCDs, you might have noticed that the location for most of these services are not close to each other. And without guidance to the patient, they usually get lost. Other stuff that you might notice are long waiting times, limited days that are scheduled for these services in these areas. So we hope by establishing this one-stop shop, we might tackle these issues. And I think the addition of these services to the SOPD clinic will boost the services provided to the NCD patients. The special outpatient clinic was recently established in March 2021 because there were plans to decentralize the public health NCD clinics. So the plan to decentralize these services was to move away from a clinical-based setting to a more community-based setting for the NCD clinics. But the establishment of this SOPD clinic is not to replace the previous public health NCD clinics, but just a mere addition to these services. This SOPD clinic is open from Monday to Friday in the afternoons. And when we first established this SOPD clinic, there were 3 physicians and 4 nurses. And of the 4 nurses, there was 1 nurse eye specialist, but we recently lost that nurse eye specialist. Currently, we still have 4 nurses, but 2 of them are currently trained in foot care and eye exam. I brought up the nurse eye specialist because during the period that she was with us, we had data that showed that there was improvement in dilated eye exams. Next slide. As I mentioned, there was improvement in dilated eye exams. In this data, it shows that when we started in 2021, you could see from 2020 there was a decline in these eye exams. And when we started the SOPD clinic with the service of doing dilated eye exams, we saw a sudden increase up towards 24% dilated eye exams in the clinic. So it showed improvement. The only reason that has declined in the recent year is we lost that eye nurse specialist. Next slide. So the 3 services that we've recently added to the SOPD clinic is, first one is eye care. In the eye care, the services that are provided to the NCD patients within that clinic is visual acuity to check for vision. We also do anterior eye exams to check for cataracts. And then they also do retinopathy imaging and exam to catch patients that are at risk to blindness from their diabetes. Next slide. So it's just imaging of in the clinic with the nurses doing the dilated eye exam. Another service that was recently added was also to do foot care within the clinic. In this service, we provide monofilament tests. This is to check sensation of areas that are most prone to develop ulcers and to catch patients that are at risk to develop ulcers. And this way we can manage them better and prevent these ulcerations and later preventing amputations of these patients. Also, they do pulse check and they also do education about self-foot exam to teach the patients how to check their own foot and also advise them on proper footwear. So the last service that was recently added was point of care HbA1 testing, and this was recently added to do the A1C testing within the clinic. So this is not to replace the lab because there are more labs that should be done, but with just doing the HbA1C at the clinic, we're able to identify whether the patients are controlled or uncontrolled and then manage them. This way we can have a better and accurate assessment of the patient's sugar, and that way we can change up their regimen and better control their sugar. So this is just imaging of the 2 HbA1c testing machines that are currently in the clinic where we do our testing. So in the future, we plan to add more of the services that I've mentioned before to have a more comprehensive care of the NCD patients. And we hope to adopt this plan into the community-based approach. This way, when the NCD clinics that are based in the community, they can have a whole team that can assess patients and then send them in to the clinic if they're needed to be seen. We have 2 challenges to this one-stop shop. First is staff. There's only few of us and only few that are trained, and retention of staff. Currently, we'll have one that will be currently hired by the hospital, so she will be taken away from the clinic, so we won't have an personnel to check the eye. So that's an issue and a challenge. And our biggest challenge is space also. Hopefully, in the near future, we may have more data to support that this is a good approach to NCD care. Thank you.
Thank you, Dr. Kyle. At this time, I'd like to invite our Wellness Center Director, Tanner Smith, on RMI NCD policies update. Come on.
Can you hear me okay? Yeah, okay. Good? All right, so I'll be presenting on, no, not okay? Okay, hold on. How about this? All right. So I'll be presenting on kind of what's been done already as far as policy goes, and then where we're at now and where we're going to be hopefully in a year or 2 if we're really good. So next slide, please. Okay, so where we have already done policy work is a lot in the sector of city ordinances. So this is a local ordinance only affecting Madra Atoll. And we have 2 such things. We had the Healthy Diet for Healthy Futures. So that came out quite a while ago in 2018, 2017, 2018. Somewhere in there. This one's really interesting because it says within 50 yards of any school property, there are restrictions to what can be sold at the stores and also what can be brought into the school. And what I didn't put up here was also PSS coupled this with public law regulation within its own department, saying that the teachers also were banned from selling or bringing in any kind of junk food. So we saw a great decrease in the number of wrappers and junk kind of trash were laying around the school because the kids weren't bringing it in anymore and the teachers weren't bringing it in anymore. And then at the stores, what a lot of the principals reported back to us were that they switched from selling like the donut and the chips and stuff like that to selling hard-boiled egg instead. So they would go through, several dozen eggs in the morning instead of several donuts and chips and such. The other one that just came out, 2020 is when it came out, but we didn't actually start implementation for a few years because of COVID issues, basically. But this one is in conjunction with local government, getting the stickers to be put onto the cigarette boxes, cigarette packs. So the whole goal was in this one was to decrease the amount of illegal importation. And then also we had to say no single cell cigarettes. So that also targets the youth because a lot of the high school students, they won't buy a whole pack of cigarettes, they'll buy just a single cell. So the stores can't sell those anymore on a single cell, on Madro at least. So next slide. Okay, so right now, like everybody, I think several people have mentioned already, the canteen policy is coming out. We're just kind of waiting for PSS to cross the T's and dot the I's on that one, and then it'll come out. But basically this one is at a national level, so it'll include all vendors, both on Madro, Ebi, Outer Islands, and it does ban certain foods like hot dogs, ramen, corned beef, so forth. And it also incorporates local foods into the diet. So this one's going to be coming out another month, maybe. And then the PE curriculum, I got word, is also coming out. So with the sports and extracurricular program, SEP, they will be the ones that will be implementing this, and we're kind of helping out and backing them up. Okay? And then what's coming out next? The marketing restrictions regulation. This one has gone 1 month at least through public opinion and is ready to go out to cabinet now for approval. The neat thing about this one is it will restrict what the stores can advertise specifically to children under 18. So this one, we've been working with WHO and CDC, MOH, just about everybody out here that's here today. We've been working, getting this one ready to go for like 3 years now. So it's finally ready to come out. And then the next one that will probably have to wait until next year now is the Tobacco Act Amendment. And that one we've been working on for a while. That one will ban e-cigarettes and ban single-cell cigarettes at a national level, along with some other updating definitions, so we're more FCTC compliant on that one. So those are, that's basically what we've been working on. So I think that's all. Thank you very much. What? Sit there? Okay, no questions allowed.
Thank you, Mr. Tanner. Can we have, please, our physical therapist, Director of Rehabilitation from the Ministry of Health, Manny Nunes, to present on rehabilitation therapy status.
Yakwing Anolep. Mukrara. First of all, I'd like to give thanks for this opportunity that our rehab will be heard of what's happening in the rehab. And I would like to thank our the NCD Task Force for giving me also the, accommodating me, because I was supposed to be talking tomorrow, but since I was busy, I scheduled for this afternoon. And I was also asking my boss that what should I talk to with regards to rehab. Then I think it would be better to give you an understanding of the SWOT analysis of what rehab is all about. Next slide. This is our rehab team. For those who have not been into rehab yet, if you see those persons, Edward, May, who already left us, James, Rosie, me, and Winalyn. Our PPI output group, 2.3.4, the rehabilitation department, and to ensure effective and efficient rehab services is our motto, or what we are supposed to be doing. Next slide. For our strengths, actually, I don't know if this is really our strength, but this is the things that what we do in rehab. One is we cater to inpatient and outpatient services. Most of those patients are diabetic, the stroke ones, and other are musculoskeletal patients. We also cater some pediatric cases, like those people who have cerebral palsy and congenital diseases as well. And then we also have the wound care center. Thank you for from the Swanghu Hospital. Actually, we used to only have the diabetic foot clinic, but they upgraded our wound care center now. So we cater all kinds of wounds from top to bottom now. And for those people that we were not been able to prevent them from, the diseases or the wounds gets worse, we have our prosthetic and aesthetic limb fabrication for those who are below knee amputee patients as well. And we do outer island and community outreach programs. If you see Edward running around, he is actually assigned for community services. And if going with the outer island together with the health promotion and the NCD as well to do rehab and also foot care as well to those patients in the neighboring islands as well. And here in Majuro, we used to also let him join the public health and also the NCD in doing the profilings and other patient visitation as well. In rehab, we also do diabetic foot care training. I usually conduct those training maybe sometimes once or twice a year in training some of our staff. I think some of our staff in the MOH also were audience of those trainings. And we do as well wheelchair assessment and prescriptions for those patients that needs to be prescribed by wheelchair. And of course, we have somehow well-equipped fitness gym. We take pride of our gym now as compared to the other gyms if you have been to any other rehabilitation within the Pacific Islands. I think the rehabilitation department of the RMI is more somehow upgraded than most of the Pacific Island rehabs. Next slide. Our weaknesses, these are the things that actually needs improvement. One, we are not yet a multidisciplinary clinic or a holistic rehab because our staff is only a physiotherapist. We actually needing an occupational therapist as well. We should be having a speech therapist and other forms of holistic treatment of a patient. We also need a staff development. Our staff needs to have more somewhat detailed upgrade of the skills that what we know and what we need to know. Okay? And of course, manpower needs, because of the growing number of patients that we have, we also need more manpower. Since they have added this wound care, we need a wound care nurse actually, and of course another therapist. And lack of funding, of course. I think, I don't know, of all the department in the Ministry of Health, I think rehab has the lowest budget. So anyway, we need funding. So we're looking for budget. Next slide. Opportunities that we would wanted to tap on is one, the National Strategic Planning for Rehab in the RMI. We would wanted to initiate the start of this strategic planning so that we would be able to be a part of the national standards, or so that our rehab will be also within the standards of the world. Also, continuing education and staff trainings, not only skills-wise, or even personality development, we also would wanted to have our staff be developed. Use of MHIS, although I think we are, the MHIS is working now, but on the aspect of rehab, we would wanted to put or encode as well the things that what we do to the patient and some of the inpatient as well. So we also talk with the IT of the ones who are doing the MHIS, and they are on process now of including our we call it patient encounter in the MHIS as well. Of course, we need to upgrade all the equipment that we have, even though we are having some of the equipment, but we need more upgrades. Plus, we need an added expansion in our rehab. I think it's because of the equipments that we have. The rehab is getting smaller and smaller. Some of you have been there on our MOH General Assembly, and it's now getting smaller, so we need a bigger space. For the threats, we all know that the world is changing and upgrading, so we need innovation, and technological advances need to be applied in our rehab as well. So we would wanted to, as compared to other rehab, they are more advanced in their technologies, such as robotics and shockwave therapy. So we would wanted to have that as well. Another threat that we have is the employee turnover. One of our staff just left a month ago. So actually we are open and looking for a physiotherapist. If you have friends, just apply at PSC, those who have licensed physiotherapists. And of course, the limited staff resources. We are always somehow saying to our patient or our staff, emal noche ni chalok. So, but we need to be resourceful of what we already have. Next slide. This is our future plan. If you could see the left, right side, that is what we can do in the rehab. Just the old type of prosthetics. But we would want it to have the more modern type 1, the ones on the upper left. And since we also only can do the below knee, we would want it to have our staff be able to do the above knee as well. But we need more education and more equipments in doing that. Or the more sophisticated and modern amputee prosthetics, like the cosmetic type or the athlete type of prosthetic, we would also wanted to have that. And lastly, if you could see the rehab now on the upper right, that's our rehab. And onto the future, we would wanted to have a robotics department, an aquatic therapy, and also a wall climbing rehab. So, next slide. Let's make it happen. I'm looking for funding and looking forward for the next budget that we have. Hopefully, our rehab would be able to, have just a piece of those things. Thank you very much.
Thank you, Manny, very much. At this time, I'd like to have our panel discussion for questioning and answer for our presenters. Are there any questions for them? They are ready to answer all your questions.
I have a question. Okay. I will ask maybe a question mixed with comment and probably follow up with a recommendation from the doctor from Taiwan who speak on the renal problem or dialysis. Let me give you a little bit introduction of dialysis in our place, in RMI. We used to have dialysis long time ago, up until 1980 some. We closed the dialysis program here in RMI. Or if I recall, some of the reason is cost, and the other one is many of them are diabetes client, which at that time we were also promoting prevention, and we were aiming that prevention for diabetes can also prevent dialysis in the future. There was no dialysis from 80s or late 80s up until now. And right now, there is a plan to bring dialysis back into measure. With listening to all your presentation, dialysis, as you mentioned, it's only provide 10% or maybe small percentage for the quality of life. There are bunch of burden aside from dialysis alone. You name it, other sickness and costs, including the medicine, they are also costly. Water, providing water is also, you need a sterile water. There's also cost. And the question for you and the recommendation is, we need your recommendation. Because like I said, we are about to bring dialysis back into Major Hospital. In your presentation and point of view, are you with the RMI bringing dialysis back home? Given all the information you mentioned. Thank you.
Okay. Thank you very much for your excellent questions. So I think this is the reason I present these lectures at this time point, because I know there have been quite a long times to prepare for this dialysis in IMI, right? So this is why I'm thinking about considering the dialysis itself to establish the dialysis unit here. It's challenging, but not that challenging, to be honest. It's just the money to set up and the machine. And you build up the RO system. But one thing is, once you initiate this dialysis program, the problem coming up. So the problem first is the maintenance. The maintenance, okay. So the maintenance is the quality of the stuff, the well-trained stuff. And the other thing is the maintenance of the machine, or this water purification system. And this is considering a very big burden. And so need to think about in advance, but also think about the how to do the medical team. So the team is not just doing the dialysis. As I mentioned, this you just actually replace the like 10 to 15%. So they still as a CKD patient, they still have the many symptoms, many symptoms. They need to be cared. Many drugs they need. The drugs for the CKD patient do not decrease even after dialysis. That's the problem. So the dialysis treat actually is just prolong their life, but actually not eliminate their symptoms much. So that's the questions. So transplant is still the best, but the donor kidney is the problem. But for me, I think it's the RNAi system is the CKD prevention and the early detection. Keep prolong their process to delay their enter into the dialysis stage. That I think is still the very important things. The reason I'm not talking CKD is talking a lot in the NCD clinic, but this is just talking dialysis. But actually, I emphasize the importance of the CKD program. In Taiwan, we actually put much money on the pre-ESRD CKD program because we already see this growth of the budget. So we want to block them, stop them. So the only way to stop them is just not going to the dialysis. But the thing is that dialysis is one, for me, is most important. If you have the dialysis capability, actually you can treat acute kidney injuries. That is the one thing I didn't mention today. So the cost of the maintenance for the chronic dialysis is huge. But for the acute kidney injuries, it's life-saving and it can be recovered. So the setting of the dialysis unit in the hospital, major hospital, there's one thing most important is actually you can treat acute kidney injuries. Because from my understanding, if you have the diabetes background, right? You have to suffer from the, let's say, infection, sepsis, right? That you have the acute kidney injury. But if you treat the right antibiotics and the proper dialysis, actually they can recover. They won't be going to the long-term dialysis. So I think this is also a very key point. Even you set up even someone set up the dialysis unit for you, I strongly recommend that you can still train your own staff with this intensive care capability to treat these acute kidney injuries. Because they will actually block this process leading to the end stage. The acute kidney injuries is reversible. So the dialysis is a very key component. For long-term dialysis, I'm not very prefer. Either it's a peritoneal or hemodialysis. They all very suffer, honestly, very suffer. There's people living with the dialysis. I think if you have a family in the States or other places using that, they actually very suffer. The quality of life is not very good. I honestly say that. But to manage their symptom is approachable. I think it's still approachable, but you still need a good team. So from me, before the dialysis set up, the unit set up, I think the implementation of the good quality of care of the CKD probably very important. This is why Taiwan Health Center, when trying to do this kind of the integrate, because this is a component of the diabetics, cardiovascular disease, and the kidney disease. They need to be cared together. Yeah, they need to be cared together, yeah, to block this process, yeah. Yeah.
Thank you very much. That was a very excellent and good informative information. And yeah, from listening to you, the beneficial is for the acute kidney failure and also straighten the CKD, either clinic or whatever, just to maintain them at the CKD stage 1 or 2 and prevent them from going into the later stage, which is a dialysis stage 5. Thank you.
Hello.
Are there any more questions? Yes.
Just want to elaborate more on Zach's. From the ministry's point of view, it's always the primary prevention and primary care to prevent these complications of diabetes. It's always our aim from the beginning. And looking at our numbers, our data is from what Dr. Frank just presented, Dr. Underwood, our prevalence of diabetes remains same. So you will continue to see a lot of complications, end-stage renal failure especially, and it's becoming a political issue that is, if you look at it, bringing a lot of burden to our society with a lot of young folks dying early. So it has been a political issue that they want to establish a hemodialysis or dialysis on the island. And if you guys remember, 4 years ago, hemodialysis committee was formed from cabinet for us to find solutions that we need to bring in dialysis, either it's a peritoneal or hemodialysis, and definitely it's a kidney transplant is the key. So what the committee has set up is we've listened to what Dr. Schwanger Hospital has presented to us. We agreed that that's the way to go. However, there were some other challenges that came from the committee that in RMI, because of our environment, a lot of diabetics, and in one household, you'll have plenty folks in one household, and you will receive $3 a day. I don't know if that's feasible. Then we discussed, what about bringing them to the hospital and dialyze them to the hospital? Now, bringing 3 times a day a person to the hospital is going to be a challenge. Just imagine patient trying to just follow up. They don't come for follow-ups. So it's going to be a big challenge. So what we all agreed at the end was, actually there was a charitable organization from New Zealand that wants to help us to come and set up hemodialysis with Major Hospital. We work on a contract with them. So it's going to be a 10-year contract. All we have to do is pay the group, and they'll bring in their staff, the equipment, they'll set up everything. While they're doing dialysis, starting dialysis, they'll be training our staff. And then every 2 years, they will start with 4 machines, which can treat 24 patients. And then after 1 or 2 years, they'll add 4 more machines, so we'll have 8 machines, which can treat 30-some patients. And like what Dr. Liao has mentioned, it's going to scale up, of course, it's going to scale up. But hemodialysis is just a supporting process. You're not going to live for a long time. The only treatment is actually kidney transplant. So there's another, we put to ESA committee, that's the Health and Education Committee, chaired by our former Minister Kalani, basically to have 30 years and younger eligible for dialysis. Because in the current Health Fund Act, in 4U, hemodialysis, it's an exclusion, meaning if you have kidney failures, you're not eligible for basic health plan or for referral. So now it's in the ESA committee that anybody that is 30 and younger, if they have kidney failure from glomerulonephritis or infection to the kidneys, they can be eligible for kidney transplants. And kidney transplants has actually come all the way down, including also consumables for hemodialysis, not like compared in the past where it was so expensive. And there are ways we can cut hemodialysis. What we did in Palau is instead of doing 3 times a day, we actually cut it down to twice a week. And then to those that really need 3 times a day, then you continue on with 3 times a day. And Palau currently have, 14 machines, and they're treating only 30-some patients. And their initially cost that we started with, we requested for 800,000, and by the time we start utilizing it and we revise our protocols, actually we were only utilizing about 400 to 600 for those 30 patients, 30 some patients. So, you know, we can debate on hemodialysis and any kind of dialysis forever, but the only solution is prevention. And that's why we need to turn those taps off. If you see the guy mopping, that's me mopping. I don't want to do any more mopping. Because if you have more dialysis, you're going to be mopping more. So, you know, this is a good chance. You know, we need to, the gentleman that talked earlier today, and I really look at him because, you know, we really need, this is a community government effort. Whole society needs to come together, and we need to address this and really concentrate on our primary preventions, which are your primary, which are your health promotions, and then your health protections. These are your health policies, and that's your taxing. And those, it's good to have these laws in place, but are they enforced? Because if you go around now, people they're still selling one piece of cigarette, even though it says it's banned. So these laws that are in place need to be enforced. And lastly, we need to you know, improve our clinical setting. And like what Dr. Kyle was saying, is not just doing NCD clinic in the hospital, but we need to decentralize, not just to the community in Majuro, but improving care in neighboring islands. We have a lot of referral from neighboring islands, and these are all diabetic related. And focus those primary preventions on those risk factors. Anyway, sorry, I moved a little bit from the renal dialysis. Thank you.
Thank you, Dr. Madison. Any other questions? Yes.
Yakwe, my name is Tavaita. I'm a public health nurse, one of the profiling task force. This is maybe a suggestion and recommendation to the one-stop shop. From my experience during the past 3 months, been going out in the community for profiling, we have found out a lot of patients that they are non-compliant, and there are a lot of NCD patients out there. They are already living with complications. So, for us public health nurses, we are there to save life. So, my suggestion, what can one-stop shop or the ministry hire a counselor or nurse educator on NCD? We cannot only rely alone on medications, but these patients, they need a strong health education and awareness. That's the only thing can prevent the complications from happening. Is there any plan for the one-stop shop to hire a counselor? We cannot be relying on mental health to bring them and to go and counsel all our NCD cases, but I believe we need one at the one-stop shop or public health especially. Because what we found out that a lot of patients out there living with NCD, they are not taking their medications. When we check their basket, they have medications inside. And we try to convince them to take the medication. And we tell them the importance of taking that medication is to control their blood sugar and blood pressure and to prevent them from complications. I believe we need educators or counselors at one-stop shop, something to prevent them from there before they go out. That's for the one-stop shop. And the second one is to the wound care center. Sorry, I'm also from wound care. I'm a food care trainer too. And we found out a lot of patients living with diabetes in the community. I'm sorry to say this, we public health nurses, we are advocates. Some of our patients cannot speak. They cannot voice their concern to the doctors. Maybe they are shy. So we are here to voice out their concern in this room. We have found a lot of cases who have wounds. Some they've been discharged against medical or surgical advice. We have directed them back to the hospital to save their life. And then to Dr. Alfred who will help us to save one patient living with diabetes who discharged against surgical advice. I believe this person has already had surgery. Unfortunately, we have lost one this morning. This charge against surgical advice last Sunday. We went there with the team yesterday. We were so sad to hear the news that she passed away this morning. But I want to ask one question. Is the whole of Majuro Island know that wound care center is for free? Because some of them, when we tell them, when you have chirik problem on your foot, you need to come to the hospital. But the only thing they always tell us, no, we don't want to come because we have to pay $5. Can we announce it or made it like in the media for all people living with diabetes, if they have wounds in their foot, chirik, to come to wound care center? But the challenge here at wound care center is the staffing. We need more staffing. I believe the theme, bridging the healthcare gap, and we are here for that, for the patients, to save their life and save their feet from amputation. We don't want the whole of Majuro Island to lose all their foot. Maybe in 20 how many years time, we don't want to see all of them in the wheelchair. So we are here to help them to enjoy their mobility using their 2 feet. Can we make it aware in the media for the people living with diabetes, if they have problem, to come to wound care center? Because the main problem here is going to the outpatient. They have to pay $5. Thank you.
Maybe, MC, if I could just add an injection, maybe part of the answer to that question. This is a very important question and an important observation. I also brought it up in my presentation that even for individuals who are on treatment with both high blood pressure and diabetes, percentage who have control is very low, even though they have access to medications. And that maybe there's an underlying lack of understanding. In short, we are short of staff in the NCD clinic. Dr. Kyle also highlighted that in his presentation. So moving into 2024 and with more funding, Compact 3, as part of our planning processes, we can try and allocate funds for more staff in NCD who can also be counselors. The second one is behavioral life coaching. Okay, it's very important. That's often a community component. Right now, the Ministry of Health does not have the capacity to provide that, and we rely on our NCD NGO collaborators like the Wellness Center, the REACH project, who have lifestyle coaches and programs in the community that they can enroll people in, where they can undergo the coaching, the counseling in their communities. That program needs to be scaled up as well. The vision is we have a lifestyle coach in every weto, who a person with diabetes in the households around there can go for counseling and equipping them to be their own managers of their chronic diseases. So thank you very much, Tavaita. I think we've taken that on board. That's a very important gap, and we need to close it. Thank you.
Thank you. Any more questions before we move on to our raffle, our little break? Aside from our audience, do we have any questions from our online viewers or participants virtually?
I have one.
Go ahead.
This is to rehab.
Yes, rehab.
Because of you mentioned all his weaknesses, so I just stay tuned for Compact 3.
Okay, if there's no more questions, I'd like to ask Nikki again to come forward for our raffle. At this moment, we will have our break for 5 minutes, 5 to 10 minutes. We have some refreshments at the back, so please help yourself. Then we'll come back for our next presentation. Kumol. I'd like to call up our program coordinator, Suzanne Filippo, to present on cancer screening rate, data, and update. Oh, excuse me, Nair Kabua. Come on.
Komol Jean. Short. Thank you, Jean. I'm not Suzanne Filippo. My name is Nayar Kabua. I'm the director for the cancer program. And unfortunately, Suzanne, she called in sick just like 5 minutes ago, and so that's why I was kind of nervous. But it's okay. I'll present on behalf of the program. With me, I have Taurus Simon. She's our nurse. She's our patient navigator. She also works with Suzanne under the Breast and Cervical Early Detection Program. Also, we have Toli Nataming. She's also works under me. She's a specialist and program evaluator for CCC. Who else did? Oh, we also have our cancer registrar. She's over at the office, but she also she's under the program as well. The program works with community partners such as With Me, MyEpi, wellness program, and we try to reach the outer islands or neighboring islands by working with our mayors, the local governments. So this is an ongoing effort to increase our coverage for screening as well as vaccinations for HPV, especially at this time that cervical cancer is among #1 in the world. Our incidence rates are up there. So this is something we want to strengthen our efforts along with our partners and our other MOH programs, such as immunization, reproductive health, and so forth. But for now, I'm just going to present one component of our program, which is the screening programs for breast and cervical. So the mission of the program is Healthy Women Program to reduce morbidities and deaths due to breast and cervical cancer among the Marshallese women by increasing number of women screened for these cancers through PAPs, HPV tests, clinical breast exams, mammograms, and diagnostic testing and follow-up care. So here's a graph of the top cancers in the RMI. You can see that cervical cancer is our #1. If you go down the row, you'll see an alarming rate of the percent of deaths within 5 years of diagnosis, which is very high, 43%. The second leading is lung, and third is our breast. Okay, so some highlights for 2022 and 23 for the program are maintenance of staff and consultancy necessary to support FOA implementation, and the reimbursement system was established. Electronic cancer screening and tracking system we call CAST that reports minimum data elements is up to date, and we have begun utilizing it for client reminders for follow-ups. Program maintained MOUs with our clinical and community partners, and we have a new mammogram in Madro is fully operational. And successful OBGYN recent Canvas Back mission, which in 2 weeks' time we had about 500 women come and get screened. That number is our annual goal, I guess, because it's really hard to get women come for our regular clinic with our local OBGYNs. So this is pictured here is our new mammogram. So this are our breast cancer screening rates. They mentioned the hybrid was done 2018, but for these kind of data, we need annual. So the program does, what do you call those, chart reviews. That's the minimum data that we can acquire at this time because we cannot, well, now we can. We're just waiting for the hybrid. So I know MyEpi tells me that it'll be ready by March, or hopefully we get a most up-to-date data. But yeah, here you can see that it's very low, our screening rates, still in the 20 percentiles for breast cancer screening. And this is what Secretary mentioned a proclamation of breast cancer for this month. So this is another initiative to increase our breast cancer screening rates. This graph of our cervical cancer screening rates, you can tell it's also low. We want to target more than 50% for the next few years. So for cervical cancer screening, we're in that far right percentile, 15%. So it's been very low. It's affected because of our recent COVID. And so we had to halt all screening services for our pandemic. So yesterday, we presented our cervical cancer policy to one of our women's group that help us bring in women to get screened. So we need all the help that we can get to get everyone, the women, screened. Here are pictures of our after-hour clinics and some of the outreach programs that we do. Dana and P-Tana and Torres, and I want to thank all the hard-working nurses and doctors that help us with this screening program. And yep, that's all. We talk about turning off the tap, stop, decrease our mopping because our arms are getting old, right? So we need to, I guess, promote more prevention work for NCDs, and especially get our women, our people, screened earlier for NCDs to save lives.
Komolder. Our next speaker, I'd like to welcome Dr. Shu Han Lee from Taipei Medical University, Shuanghe Hospital, to share mobile cancer screening bus experience sharing. Come on.
Okay, now we are going to share our PowerPoint. Okay. Hello, everyone. This is my great honor to share our mobile cancer screen bus experience with everyone here. I'm Dr. Xu Hanli from Department of Family Medicine. Before we get into cancer screen, I would like to introduce the concept of prevention medicine. First, the primary prevention is to control multiple risk factors to prevent disease develop. Secondary prevention is implementation of a screening program for early detection, and the early detection of disease may followed by early treatment. And tertiary prevention is providing universal health care and better access to the best health care, and helping patient recovering from disease. This picture, as we can see, this is our achievement. Since 2005, our government promotes a large scale of cancer screening program, and we can see the incidence of cancer goes up. The reason why cancer incidence goes up, that may be related to cancer screen itself, and also may be related to advancement of diagnostic method. However, incidence goes up, cancer mortality rate decrease. So that means our cancer screening program can truly decrease cancer mortality rate. This one is our key point, secondary prevention for cancer through screening. During past 2 decades, we only focused on 4 kinds of cancer, cancer, including breast cancer, colorectal cancer, oral cancer, and cervical cancer. And since 2022, our Health Promotion Administration started to cover the lung cancer screening fee, and the focus on the 2 kinds of high-risk group, including people have a family history of lung cancer or heavy smoker. This slide can help us reviewing our cancer screening policy, including cervical cancer, breast cancer, oral cancer, colorectal cancer, and lung cancer. We cannot screen everyone in Taiwan. We cannot screening every cancer because that will be too expensive. So we need to target cancer screening. We need to form the age criteria and frequency of screening and focus on high-risk group. This slide tells us how important cancer screening is. In cervical cancer, out of every 2 screening positive cases, 1 is diagnosed with cervical cancer. And out of every 20 screening positive cases, 1 is diagnosed with colorectal cancer. And in breast cancer, every 17 screening positive cases, 1 is diagnosed with breast cancer. And every 9 screening positive cases, 1 is diagnosed with oral cancer. So cancer screening is very important. So why we need to do the cancer screening? Why we need to detect disease earlier? Because we can, according to our statistic, detect disease earlier and treat the disease earlier, that can decrease the cancer mortality rate. For example, if we screen in Taiwan, we screened people aged from 50 years old to 75 years old with fecal occult blood for colorectal cancer, and that can decrease 35% of colorectal cancer mortality rate. With adequate cancer screening, we can decrease 26% of oral cancer mortality rate. And in breast cancer, with screening, we can decrease 41% of breast cancer mortality rate, and decrease 70% of cervical cancer mortality rate. And with lung cancer screening, we can decrease 20% of lung cancer mortality rate. Okay, so this section we'll going to talk about how cancer screening performed in Taiwan, especially with our mobile cancer screening bus. So first is breast cancer screening. We can see this bus is our mobile cancer screening bus. We can drive the bus to the community, and people, yes, people only need to take a short walk from home, and they can receive the cancer screening. And the principle of breast cancer screening, the image is made by X-ray, and using X-ray, we can detect suspicious or tiny lesion in the breast tissue. And go back to hospital, radiologist can find the suspicious lesion or any positive finding. Patient will be referred to specialist for further diagnostic workup. This one is cervical cancer screening. Our cervical cancer screening method is Pap smear. Women aged over 30 years old, they can undergo the cervical cancer screening with Pap smear annually, and with multiple times of negative result. The frequency may be changed to once every 3 years. And if people still wish to undergo cancer screening annually, the coverage will still be applied. So it means you can choose every 3 years, once every 3 years, or annually. This one is colorectal cancer screen. Our policy is aim to find people aged from 50 years old to 75 years old people, and we screen colorectal cancer with fecal occult blood. When we drive our mobile cancer screen bus outside, we can also give patient or people cancer screen kit, and they can collect their stool and send back to hospital. And if there are any positive finding, they will be informed to come back to hospital for further diagnostic workup like colonoscopy. And this one is oral cancer screen. In our country, we screened people age 30 years old, over 30 years old, and beetle not showing or beetle quit sure, and smoker. And our method is doctor will examine the patient's oral cavity directly, and if there are any suspicious lesion, patient will be referred to specialist for further follow-up or biopsies. This one is lung cancer screening. Our lung cancer screening method is low-dose computed tomography, And we focus on two kinds of high-risk group. First one is people who have lung cancer history, like parents or brother and sisters have lung cancer. And another high-risk group is heavy smoker. Right. So the most important thing is not to do the cancer screen. The most important thing is need a patient to come back to hospital for further follow-up if there are any positive finding. So we will make the phone call to inform patient the necessarily they need to come back to hospital for further diagnostic workup. Okay, now this section we will introduce our mobile screening facility. As we can see, this one is our bus, and we are emphasize people's privacy. You definitely cannot see inside from outside, so that you can make people feel free to undergo cancer screen in a mobile screening bus. In my experience, according to my experience, I think the huge obstacle for a patient to receive cancer screen is transportation and the traffic. Sometimes that will be a big trouble. So if we can drive our bus to a community, patient can take a short walk from home and they can receive the cancer screen. That will be convenient, and they will feel easy to have cancer screen. And this is our facility. This one is mammography, and on the right side, that picture, this one is for cervical cancer screen. And we also emphasize on the privacy. Okay. This is the award we received. That means we save most of life of cervical cancer patient compared with other hospital in Taiwan. So this is our award, and in summary, we have some strategy to promote cancer screen. Like, for example, we will prepare gifts. If people get cancer screen done, they can have a gift at the same time. Or we can use broadcast to notify people in community. Like right now, we have cancer screening activity in the left corner of Central Park, something like that. So people can know they can come to receive cancer screen. And many cancer screening were shut down because of COVID-19 pandemic. As we can see previous report in Marshall, and this is right time for us to restart cancer screening and disease prevention and health promotion. This is my presentation. Thank you, everyone.
Thank you, Dr. Shu Han Lee. Please stay online for our panel discussion later on. I'd now like to welcome our Director of Health and Promotion, Leilani Perrin, to talk about the REACH project update.
Yakoy Olep. Yakoy Olep. Like Dr. Jean was saying, my name is Leilani Perrin, and I work under the Health Promotion and Disease Prevention Division under the Primary Healthcare and Primary Health Care Bureau. So the REACH project stands for racial and ethnic approaches to community health. And this project has been on and off since 2014. Our first funded staff under the project was Tolina Toming, who was the project coordinator at the time. The REACH project effort is to address racial and ethnic disparities in health. And the RMI REACH is in partnership with the Ministry of Health and Human Services. And due to high rates of NCDs in the RMI, such as diabetes and hypertension, the project aims to implement health interventions on tobacco, physical activity, and community clinical linkages for healthier RMI. And under the tobacco activities, this project aims to work with the current tobacco program in the Ministry of Health and its partners on existing policies in public settings. For physical activity, to create actively and friendly route in public places to encourage active living. And under community linkages, community and clinical linkages, to work with health clinics and medical providers to connect and guide patients to health or community services and program. That was just the introduction. Can you go back to the slide, first slide? So Lisa Johnson is not here, but she's the local staff working with the REACH project. And like I said, REACH stands for Racial and Ethnic Approaches to Community Health. And this is funded under the University of Hawaii and subcontracted to the Ministry of Health and Human Services. And the three main strategies, like I mentioned, one is physical activity, tobacco, and community clinical linkages. So for physical activity, you can see in the picture, this project has been working closely with the Marshall Island High School to repaint the crosswalks and put up signs and also install solar lights. So this is the before crossing path and the after it was painted. Next. Next. So currently we're working with Ministry of Public Works and Infrastructure, and the crosswalk between the K&K parking lot and Della Park. So this is going to be like the second time that they're repainting that sidewalk, and that's one of the challenges. I guess the paint that we use, it doesn't stay too long. And yeah, next please. Yeah. So this is Malgov and Public Works. For the tobacco project, you can see here, if you go to the airport, you can see the sign, a no smoking sign. It's also installed in both parking lot at the VIP site and the main parking lot. So here is, for policy enforcement, we installed two signs and designated two smoking areas within the hospital. So one is by the wellness center, and the other one is um, by the tennis court next to the ER. So this is another sign at the Assumption School and basketball court. You can see here, yeah. My next, so it's a drug-free zone, and this is in collaboration and partnership with the school. If you look here, the project also donated some cleaning supplies to the school so they can clean up the place after they use it. And one of the success story of the project is the Flame Tree Restaurant. Flame Tree has enforced its policy smoking. Policy smoking. And so if you go to the Flame Tree, before you enter their main door, you can see the sign here. So they don't allow smoking in and surrounding of the Flame Tree. And the owners are really supportive, and and this is one of the success story this project has on tobacco. This picture here is Lisa and Dr. Frank. This is the first meeting they had on the community clinical linkages to introduce the project to get engagement from and support from the staff, the MOE staff. And this is the meetings. So under the community linkage program, we have partners, the partnership. One is with Kujile, and so this project is already implemented at the NCD clinic. And I believe Dr. Kyle, okay? The physician refers patient to these community services only if the patient fill out the form, and like there's a small form in the clinic when you go in the clinic and outside the clinic. If they're interested in any services in the community, then they're being referred by the physicians. Challenges, quality of road pain, like I mentioned before. Regarding the CCL project, slow uptake and coordination on clinical side, transportation to community programs. RMI REACH project will not be awarded in the next 5-year funding cycle. And the last day for the local REACH staff will be on the 13th of this month. And how to sustain the project activities. Way forward to sustain the project activities, to work continually with the partners. Como dada.
Thank you, Leilani. Now it is time for our panel discussion, questioning and answering. Is there any questions from our audience for our presenters this afternoon?
I have one question.
Yes, go ahead.
This is to the Taiwan presentations. For their lung cancer screening, what tools they use for their screening? Dr. Lee.
Dr. Lee? Are you online?
What tools do you use for lung cancer screening? Do you use general X-ray, or do you use CT scans or other modalities for those with risk factors? Over.
Okay, thank you. We use the low-dose computed tomography, LDCT, for lung cancer screen. So this is according to the best evidence that use lung cancer, use low-dose CT can find lung cancer earlier and decrease the mortality rate.
Thank you, Dr. Lee. Are there any more questions?
This question kind of goes to Taiwan Health Center. I noticed that I just noticed that we're talking about mobile cancer screening. Is this something that we're planning to get? Or is there a plan? All in advance.
If I can say something, one of the biggest challenges we face is that people don't come to hospital for screening. They stay at home, and we need to go to them. So what we need now is how to get our comprehensive screening primary healthcare team to communities to do NCD screening, cervical cancer screening, awareness for breast, maybe even some clinical breast examinations, maybe fecal occult blood for colon cancer screening, and maybe with a dental component also oral examinations for cancerous lesions. So how do we get them there? Right now we are having challenges with transportation. So we might need vans, we might need a truck, they might want a bus. Yeah? So there's a possibility. The question is from us, what do we want and what design and what services we want to offer. And maybe when the ambassador is present, we'll fill in the blanks. Yep. Keep in mind that the medical ship is a very important tool for us in taking our services to the outer islands. And we are hoping that with regular services with our integrated multidisciplinary teams, we can start increasing the cancer screening components when they go for those visits.
Thank you. Anyone else?
Just want to make a point. When we formulated or finalized our cervical cancer screening policy, we have decided to do away with VIAs. We'll be concentrating on pap smears, introducing HPV testing before that. So remember, HPV testing is less invasive. If your HPV test is negative, you don't need a pap smear. If it is, you do. We screen from 21 years to 65, at least once before 35, once after. We aim for a 60% population coverage. Yeah? One step before that, immunization. Yeah? Primary prevention, we want to increase HPV vaccination, 2 shots, males and females, age 9 to 12. So that's different. And then in the final phase, which is treatment, we want to make sure that we can refer more people for treatment with those with a 5-year life expectancy or mortality more than 50%. And for those with less than 50%, have better forms of palliative care for them. So that cancer policy will be endorsed tomorrow, And those targets will be the national targets for the next 7 years. And then the last thing I want to say is, with all these policies in place, we have to walk the talk, yeah? So we need to translate all of those into activities to meet our targets.
Dạ quay. Kacita na jangan tobacco. Do we have any policy in place in the workplace? And if we do, what can we do to enforce it? Come on.
Yeah, well, uh, that's a really good question. Thank you, Kina, for bringing that up. We have our tobacco program coordinator in the back, but I will go ahead and answer on behalf of our team. We do have a National Tobacco Act in place, and the Tobacco Act specifically prohibits smoking in public places. But at the moment, we do not have a specific or internal policy for the Ministry of Health. That's something we're working on to, we brought it up the previous years, but that's something we're working towards to, I know there was an issue a few weeks back, if we have an internal policy and ban using these tobacco in workplaces, like what is the compliance? Who enforces this in the workplace? Okay, like Dr. Frank was saying, we have policies, enforcement is not there.
If I can just add on to that, we are really not happy with these smoking zones, smoking areas. And we're looking at new ways of getting rid of those smoking areas and see who can enforce our policies in our workplace. It might mean our securities who are contracted, maybe the enforcers of this, but we need to mirror or be good role models. So we need to change that. Maybe we can prioritize it from the task force point of view, that we have an internal policy for no smoking in the hospital. Yeah?
Thank you. Anyone else? Yes, go ahead.
Thank you. On tobacco again, is there any policies or something in line with the cost of cigarettes to be increased? Just a question. The cigarettes to be increased, then we can get a subsidy from it. Yeah. No, can it go to 10 or what? We increase the cost of the cigarette.
Are you asking if there's
Yes. Can we increase the cost?
Yes. So like what Dr. Frank was mentioning in his presentation earlier, we are working on the importation, the syntax to increase both alcohol and tobacco taxation. But at the moment, we're one of the countries that our tobacco products are the lowest.
So to raise the tax on tobacco,
Dr.
alcohol,
Frank, can you please a little bit closer? Thank you.
To raise the tax on tobacco, alcohol, and sugar beverages, we need to go back to Nitijala. And we have a bill to be tabled, but Nitijala sessions for 2023 have closed. So this is something we're looking for in 2024, to make amendments to the Tobacco Act, which also increase taxation. Taxation works when the prices increase. Up to 20% increase in prices is associated with a significant drop in the use of tobacco products. So we are looking at increase in cost of tobacco, price of tobacco over a number of years. And secondly, we would like to have money raised from taxation on tobacco, alcohol, and sugar sweetened beverages to come back to primary health care, to pay for the national strategic plan and efforts that we are all talking about now. The other thing related to that is compliance with legislation. As we've heard, you can walk to shops and see sale of single roll tobacco. That's illegal, but still happening. The sale of tobacco to underage persons, still happening. So the NCD coalition has hired an inspector to help local government, Melgov, in the enforcement of these legislations. And I understand there is some progress. Okay? More needs to be done.
Any more questions?
Sorry, Tabaita again. Sorry. Just a way forward and a recommendation for the tobacco unit. I believe in the hospital we've seen billboards of tobacco for them to stop smoking within the hospital premises. But I've been driving that Black Pearl, the van. We've been still seeing people smoking at the back of wellness. So if we can have some, the team, the monitoring team, can be the security to monitor. If the policies will be there, we need people to be compliant to the policy. In order for the people to be very well compliant to the policies, we need committees. If we can have committees identified within the hospital or other workplaces so that our policies can be effective. Thank you.
Thank you. Secretary Matu, go ahead.
Thank you, Dr. Jean. There, Tess, for the awesome presentations. I just want to add on to Kina's message regarding the tobacco policy. And although we don't have this in place, we can also do, as management and leaders, to do necessary disciplinary actions. The verbal, the written, and at least for health, because we're able and we can do what we're, sorry, this is like breaking. We have the test. So maybe any. Test, okay. All right. So as health leaders, I think we need to practice what we preach and really be on top of it, because I understand where many of us are coming from. We go around in our campus and you see spit around our campus. You go inside the cars, you see buds, cigarette buds. And some of these nurses are saying yes because they're tired of also saying it. But if you're a leader, you're a manager, you're a director, I just want to reiterate that you have the prerogative, you have the authority to make necessary disciplinary actions. And I think it's time maybe the tobacco team to come around to all departments, at least for the ministry, to just remind us about the tobacco law and the tobacco policy, and then inform everyone of what repercussions will take place if people do continue to do so. Come on.
And maybe Dr. Holden can provide some, I don't know, prevention programs for those that are wanting to quit, that are needing help, because it's also something that we need to also provide. So thank you.
Thank you, Secretary. Any more questions? So if there is no more questions,
Hello.
one more. Okay, go ahead.
Just one for Ms. Nia Kabua. Just about the women in the outer islands. I know a few of us has gone out, but how much we have done for them. We need to get out there for them. Thank you.
Komol and Pitina. For the women in the neighboring islands, we've been, over the past years, we've been working with the mayors. Once when Ione was a mayor and Nika, we also piloted like a screening program with them and their respective atolls. After that, we work with WITME because they have chapters there. So they have their annual meeting now, and that's when we can receive them and reach them while they're here on island. So they go back. The idea is they go back and then they continue the screening programs and the messages and the awareness, and let them know that there's a program for that.
Thank you. Any more questions? Okay. Thank you, everyone, for the questioning and answering. Panel discussion. Coming down to our program, as we come to an end of the first day of the NCD conference, I hope we all have learned from our presenters as well as our participants how essentially important it is to take responsibility and accountability to combat NCD here in the Republic of the Marshall Islands. I'd like to thank everyone for your presence and participation. Before I can conclude today's program, I'd like to remind everyone our second day conference will start tomorrow at 10 o'clock. May I please ask Nurse Practitioner Dana to come forward to dismiss us with our closing prayer.
Thank you, Dr. G. Shall we all stand just to give grace to God for this afternoon and for this work, for this 2023 NCD conference? Let us pray. Iroj Jama Ilan. Iroj Jama Ilan. Our Heavenly Father, the Most High, we thank you so much for your presence in today's meeting, in today's conference, the NCD 2023 conference. We thank you so much for inspiring the speakers today with the informative presentations that we receive. And we thank you for the participants that are present too, Father God. Lord, for what we've shared today, it is all in your hands. And you are the Supreme One to help us get through with this. We thank you for the coordinators of this conference, NCD conference. Thank you for the inspiration, for being with them, and for also with each and every one. Cover us all with the blood of the Lamb, the blood of Jesus. As we go home, we'll continue to take the messages that we learned today and share it with our colleagues and also our families. We give you back the honor, the glory to be yours and yours alone. All this we pray in Jesus' name, amen.